Good morning, everybody, and let me welcome everybody to the Subcommittee on Oversight and Investigation of Energy and Commerce. We convened this hearing of the Subcommittee on Oversight and Investigations today to examine the efforts of the Department of Health and Human Services and the Centers for Medicare and Medicaid Services to address fraud, waste, and abuse in the Medicare and Medicaid programs. This issue is of great importance to us. During the Congress and the last, I introduced the Medicare Fraud Prevention Act, which would increase the criminal penalties for those convicted of defrauding the Medicare program. As a member of Congress from Florida, I've personally seen how this issue can greatly impact my state and its citizens. During my town hall meetings last week, many of my constituents showed and shared their concerns with stories about waste, fraud, and abuse in Medicare. Recently, the Government Accountability Office listed the Medicare and Medicaid programs as, quote, high risk. High-risk programs are identified as having greater vulnerability to fraud, waste, and abuse and mismanagement. As much as $60 billion is lost to Medicare fraud every year. This is an estimate because the exact number isn't known. When my staff asked the folks from CMS how much fraud was being carried out, they had no idea. So it's hardly news that the Medicare and Medicaid programs are at high risk. GAO has listed Medicare as high risk since 1990 and Medicaid as high risk since 2003. Over the years, this committee has had countless hearings on this subject, and yet nothing seems to change. The volume of Medicare fraud and the corresponding cost to the taxpayers continues to go up and up and up. Meanwhile, the stories we hear from states like Florida continue to horrify taxpayers. News reports have indicated that Medicare fraud is rapidly eclipsing the drug trade as Florida's most profitable and efficient criminal enterprise. With Medicare fraud, the penalties are lower and the threat of violence is non-existent. Meanwhile, seniors who notice that their Medicare number is being used for fraudulent schemes often find themselves begging the government to do anything about it, often with no results. The types of fraud we're seeing run the gamut, from fraudulent billing schemes to the actual creation of fake storefronts to sell durable medical equipment and then bill it to Medicare. Once the criminals get their money from Medicare, they close up shop, open a new storefront in a new location, and start the scam all over again. The administration says that additional measures are being put in place to screen Medicare providers and suppliers and halt payments when there are credible allegations of fraud. These are good, and these are necessary steps to take, but only if they work. But GAO has said that there is much more work to be done. In 2014, the administration, healthcare, will implement massive changes. Medicare will be cut and Medicaid will expand. According to the chief actuary of Medicare and Medicaid, 20 million people will be dumped into the Medicaid rolls and $575 billion will be cut from Medicare. While we are all committed to repealing this onerous law on this side, we must also do our best to end fraud before 2014. If we can't stop fraud now, how are we going to do so while simultaneously adding 20 million people to Medicaid? We have to make sure that the focus remains on preventing fraud and abuse. Unfortunately, CMS uses a pay-first, check-later system. That must change. We need to check first and pay later before taxpayers' funds are wasted. CMS needs to fix its verification system to prevent these kinds of crimes, or we'll never get a handle on this problem. Every dollar that is lost to fraud is one that is not spent on Medicare, medical care for those in need. Fraud raises the cost of health care for all Americans. Since Obamacare will raise those costs even further, it is absolutely necessary that we get a handle on Medicare and Medicaid fraud. So I look forward to hearing what the federal government is doing to get Medicare and Medicaid fraud and abuse under control. My remaining 1 minute I will give to the gentleman from Texas, Mr. Barton.
Thank you, Mr. Chairman. The easiest thing in Washington to do is talk about waste, fraud, and abuse, and the hardest thing in Washington to do is to actually do something about it. As Chairman Stearns just said, on both sides of the aisle, we've had numerous hearings about waste, fraud, and abuse in Medicare and Medicaid, and yet the problem still obviously persists. we can't even get a direct answer as to what the scope of the problem is. It's an $800 billion combined program. Is it 10%? 10% would be $80 billion a year. Is it 5%? That would be $40 billion. Is it 1%? That would be $8 billion. Nobody knows. Mr. Chairman, I hope on a bipartisan basis this subcommittee and the full committee, under your leadership and under the leadership of Ranking Member Waxman and Chairman Upton, in this Congress actually do something about it. With a $1.5 trillion budget deficit annually, there's no question that money spent here will be money that we get a huge return on investment. I look forward to hearing from our witnesses, and I hope that they have some solutions in addition to helping us define the scope of the problem. With that, Mr. Chairman, I yield back.
I thank the gentleman, and I recognize the ranking member from Colorado, Ms. Duquette.
Thank you very much, Mr. Chairman. Mr. Chairman, Medicare and Medicaid fraud have been persistent problems that have plagued both Democratic and Republican administrations, as you have said, and it costs Americans billions of dollars every year. It affects health care providers at every level, in the programs themselves and also in the private sector. Today's hearing will focus on a very worthy target of oversight: waste, fraud, and abuse in these two systems. Medicare and Medicaid provide millions of people with access to medical services, and so it's a vital concern to this committee that we maintain their integrity. Fortunately, as you said, it's important to try to get a handle on Medicare and Medicaid fraud, and that's also a high priority for President Obama. Beginning in 2009, the Obama administration made fighting fraud a priority. These efforts expanded even more after passage of the Affordable Care Act, which contains dozens of provisions designed to help fight Medicare and Medicaid fraud. The administration asked for and received additional funding to fight health care fraud in both 2009 and 2010. They have reorganized within HHS, and they've started several new collaborations with law enforcement authorities to uncover and prevent health care fraud. In May of 2009, HHS and DOJ announced the creation of the Healthcare Fraud Prevention and Enforcement Team, or HEAT, designed to coordinate cabinet-level agency activities to reduce fraud. Under the HEAT program, HHS and DOJ have expanded the use of dedicated strike force teams, placing law enforcement personnel in locations that are identified as healthcare fraud hotspots. These teams carried out the largest healthcare fraud takedown in U.S. history last month, netting over 100 arrests in just one day. The work undertaken by the strike force teams has led to criminal charges against 829 defendants for defrauding Medicare of almost $2 billion. There's an answer to your question about the extent of this. The administration's efforts have been a huge success for taxpayers, with a return on investment that would make most hedge fund managers jealous. And thanks to landmark healthcare reform legislation passed by Congress last year, HHS and law enforcement authorities now have a host of new tools and new funding to fight fraud. The Affordable Care Act contains dozens of new provisions to fight Medicare and Medicaid fraud. The most important changes allow CMS to apply a preventative model in its anti-fraud efforts. For years, CMS employed, as you said, a pay-and-chase model of enforcement, simply paying fraudsters' claims, then attempting to recover its losses. Now, CMS has new authority to keep fraudsters out of Medicare and Medicaid in the first place. The Affordable Care Act contains stiffer enrollment requirements for all providers, mandates enhanced background checks, adds new disclosure requirements, and calls for on-site visits to verify provider information. It requires that providers create internal compliance programs, and it contains several provisions aimed at directly fighting fraud in, as you mentioned, the high-risk durable medical equipment and home health programs. The government's ability to act once it's uncovered fraud or the possibility of fraud is also enhanced by the Affordable Care Act. The Secretary now has the authority to enact moratoria on enrolling new providers if she believes that such enrollments will increase fraud risks, and she can suspend payments to providers where there's a substantiated allegation of fraud. Once fraud has been proven, the Affordable Care Act provides stiffer monetary penalties and expands the HHS Inspector General's authority to exclude violators from the Medicare and Medicaid programs. Data sharing and collection between CMS, states, and other federal government programs are modernized under the Affordable Care Act. And the Affordable Care Act provides an estimated $500 million in increased funding over the next 5 years to fight fraud, money that will return billions of dollars to the taxpayers. This expanded authority, combined with the coordinated and focused attention of the Obama administration, has laid the groundwork for a new era in the federal government's response to fraud. Mr. Chairman, as you said, the GAO first designated Medicare a high-risk program in 1990, and Medicaid joined the high-risk list in 2003. I look forward to hearing from the GAO about why this is the case and what can be done. I'm hoping that these new commitments that I just talked about can really substantially reduce fraud and ultimately produce the result that all of us want. Mr. Chairman, if there's more that we can do to reduce waste, fraud, and abuse on a bipartisan level, I would be eager to hear it, and I would be happy to work with you and your colleagues on both sides of the aisle to make sure that we can do that. Because I think one thing we can agree on in a bipartisan way is nobody wants to see money wasted, and we certainly do not want to see fraud, waste, and abuse in Medicare and Medicaid. And with that, I yield back.
The gentleman from Texas, Mrs. Burgess, is recognized for 3 minutes.
I thank the chairman, and I thank our witnesses for being here today. I know several of you we've seen before, and several of you we've seen several times before, which just underscores the problem that at the federal level we've really not done enough to address the issue of fraud. And it's been, as the reports that we have in front of us indicate, that our nation's government-run healthcare system needlessly does waste billions of dollars each year through programs that are ineffective and unfocused. Fraud analysts and law enforcement officials estimate, we've heard the figures already, 10%, as Mr. Barton did the math for us, on an $800 billion public program. That is a substantial sum of money every year, and over a 10-year budget window is truly astounding. But 10% of total health care expenditures are lost to fraud on an annual basis. The point's been raised by others. I have raised it numerous times before. How much fraud is enough for us to take notice? The answer that we all expect to see in the amount of fraud is none, zero, zero tolerance. But in reality, sometimes it's even as simple as just the lack of a prosecutorial force with the background in prosecuting healthcare law cripples our ability to go after the people that need to be gone after. And certainly that has been true in my communities in North Texas, where repeated violations by some of the same people who have multiple provider numbers but a single post office box. You can bust someone in the morning, but we're sending out payments to the same post office box under a different provider number that afternoon. Clearly that has to stop. Now, the Government Accountability Office has been able to identify areas where they've made recommendations to the Center for Medicare and Medicaid Services to prevent improper payments, some really dating back almost a decade. And they've failed to fully implement them, and that, in fact, has caused fraud to rise. If we are serious about bringing down the cost of health care and protecting the patient, not just reducing but eliminating fraud, that needs to be the goal for which we strive. Medicaid expansion under the landmark health care legislation passed last year that has already been referenced, but Medicaid expansion under the Affordable Care Act is estimated to exceed $430 billion over the next 10 years. Under current standards, taxpayers would be losing over $40 billion a year to fraud. Now, we also talk about the medical loss ratio and how we are going to control costs in the private sector, but I would just simply ask, what is a more cogent indicator of medical loss ratio? Dollars that are lost to fraud. Maybe we ought to include that in our calculation. I realize the clock is misbehaving. Let me yield back to the chairman because I think he has others he wants to recognize.
Thank you, Mr. Chairman. Mr. Bilberry, California, recognized for 1 minute, and Mr. Kingreen.
Thank you, Mr. Chairman. Mr. Chairman, I think there are many ways of addressing the potential or the existence of the fraud issue. I think that one of the concerns that a lot of people had when we were talking about expanding health care coverage last year was the President stood on the podium and said, I assure you that those who are illegally in this country will not have access to this system. Though that when the bill was passed, there was no requirement for SAVE verification. The same verification required almost to every other federal program wasn't included in that expansion of health care service. I'd like to make sure that we all address the fact that if you do not verify, if you do not use the check system, you cannot look straight-faced into the American people and tell us that people who are not qualified are going to be kept out of this system. Just by saying they're not allowed to participate in the system is as logical as saying that providers will not create a fraud because we have said that they shouldn't do it. There's got to be some checks and balances here. And just as much as we need to make sure that we're on top and checking the providers of the services, we also have a responsibility, especially after the President promised the American people that they would not participate, is to make sure that we check and have a verification system for those who are providing the services and those who are being provided those services. And I think not until we are willing to do that across the board with all of our health care system can we truly have our President stand up and assure the American people with a straight face that, no, we're doing everything possible to make sure we're fighting fraud in this country, and we make sure that every dollar spent on health care in this country is going only to those who qualify and only being provided under a legal system. I yield back.
Gentleman yields back. Gentleman from Georgia, Mr. Gingrey.
Mr. Chairman, thank you.
Recognized for 1 minute.
Thank you, Mr. Chairman. Very pleased to welcome the witnesses and both the first and second panel. Look forward to hearing their testimony. Practiced medicine for 31 years, 26 of those years in the specialty of obstetrics and gynecology. So this issue of waste, fraud, and abuse, particularly in our Medicare and Medicaid systems, is something that really, really gets to me. And some of the comments that I've heard already this morning, particularly from the other side, you would almost think that one of the reasons for adopting Obamacare or the Affordable Care Act was so that we could succeed in combating waste, fraud, and abuse. I certainly don't agree with that, and if it is true, then it will be more successful than the bill has been in lowering the cost of health care to individuals who are now uninsured. It will do more than it has done in regard to medical liability reform that was promised. It will do much more than providing a sustainable rate of reimbursement to our hardworking health care providers that was promised. So it kind of remains to be seen what is in this bill that's going to make us more successful in combating waste, fraud, and abuse. But in any regard, I look forward to hearing from the witnesses, and we do need to get a handle on this problem. I yield back.
Thank the gentleman. And Mr. Waxman, the ranking member of the full committee, is recognized for 5 minutes.
Thank you very much, Mr. Chairman. Well, this hearing is a very useful one already because we have the opportunity to educate two of our Republican members about the accuracy of the legislation that we just adopted. One of the reasons I'm so proud of the Affordable Care Act, the historic health care reform law signed by President Obama last year, is that it contains dozens of anti-fraud provisions. This legislation has the most important reforms to prevent Medicare and Medicaid fraud in a generation. According to the Congressional Budget Office, these new fraud provisions will save over $7 billion for taxpayers. The health care reform law shifts the prevailing fraud prevention philosophy from pay and chase, where law enforcement authorities only identify fraud after it happens, to inspect and prevent. It allows CMS to impose moratoria on enrolling new providers if the Secretary believes that such enrollments will increase fraud risks. It allows the HHS Secretary to close the barn door before the horses have left. The new law also contains new penalties for fraudulent providers and new data sharing provisions to catch criminals. And it provides hundreds of millions of dollars in new funding to help CMS, the Inspector General, and the Department of Justice fight Medicare and Medicaid fraud. And we will hear today about how the CMS and Inspector General have already put these funds to work. I'm proud of these efforts to reduce fraud. The second thing I want to point out is that the legislation does not allow undocumented aliens to access Medicare or Medicaid or the exchanges. And it's not just on their self-affirmation that they're not here illegally. It is based on an inspection that is required under the law. There can be done in two ways. They can either check with Social Security, get all the information to be sure that the claimant is accurately stating his or her status, or they can require the birth certificates and passports and other information documentation to be produced to show that they're not taking advantage. So these oversight hearings have a real opportunity to educate people. I can't tell you how much I think this is an important reason for our hearing. When we have health care fraud, it robs the taxpayers of funds, affects the quality of care provided to program enrollees, and saps public confidence in the Medicare and Medicaid programs. And that's why I see fighting Medicare and Medicaid fraud as a critical need and an issue where we should be able to achieve bipartisan consensus. But I'm wary of those who use existence of fraud in these programs to express purposes of undermining support for them. I do not believe we should attempt to exaggerate the scope of the problem just to foster ideological efforts to cut or eliminate them. When I hear estimates of the amount of Medicare and Medicaid fraud that have no basis in fact, or when members confuse Medicare and Medicaid improper payment rates that consist mostly of simple paperwork or clerical errors with the rate of intentional fraud against the programs, then I become concerned that members are just using fraud as an excuse to bash these programs, not to improve them. The vast majority of Medicare and Medicaid providers are compassionate and honest. The vast majority of beneficiaries of these programs desperately need the care that's provided. We need to be tough on fraud and tough on criminals who take advantage of these programs and their beneficiaries, but we can and should not blame the victim. In January, every single Republican member of Congress voted to repeal the entire Affordable Care Act, including essential anti-fraud provisions. In February, as part of the continuing resolution, every single Republican voted to ban the use of funds to implement the Affordable Care Act, including the funds needed to implement the anti-fraud provisions. That vote was penny wise and pound foolish. We're going to hear from CMS, from HHS Inspector General, from GAO about the new authority and new funding they have to eliminate Medicare and Medicaid fraud thanks to the Affordable Care Act. And I hope this testimony will make some members reconsider their views. If we truly care about protecting the taxpayer, we should support, not defund the administration's initiatives to reduce Medicare and Medicaid fraud. Yield back the balance of my time.
I thank the gentleman. At this point, we'll go to our witnesses. We'll go to our witnesses, and we have our witnesses at the table. The first is Kathleen King, Director of Healthcare Division's Government Accountability Office, GAO. She is a director of this healthcare team at the U.S. Government Accounting Office, which is responsible for leading various studies of the healthcare system, specializing in Medicare management and prescription drug coverage. She has more than 25 years' experience in health policy and administration. She received her BMA in government and politics from the University of Maryland. We have John Spiegel as Director of Medicare Program Integrity, Centers for Medicare and Medicaid Services. He's worked in various components of the Centers for Medicare and Medicaid Services. After several years working outside the public sector, he returned to federal service in 2010 as Director of the Medicare Program Integrity Group. Then we have Gerald Roy, is Deputy Inspector General for Investigations, Department of Health and Human Services. He has served in OI since 1995. He was also instrumental in increasing OI's civil and criminal conviction record and the 25% increase in OI's monetary recoveries from $3 billion in 2008 to over $4 billion in 2009. And then we have Omar Perez, Assistant Special Agent in Charge, Health and Human Service Office of the Inspector General, Miami Regional Office. He was joined the department in July 1998, and he's been promoted to Special Agent in January 1999. He's led a number of successful criminal and civil investigation and orchestrated Project Ghostwriter to address the fraudulent ambulance companies' bad medicine to address Puerto Rico's Medicaid equivalent and the first child support round in the U.S. Virgin Islands. So I welcome our panelists, our witnesses, and Ms. King, if you don't mind, we'll start with you. Let me swear you in, first of all. Do you mind standing?
I do. Mr. Chairman,
yes,
and members of the subcommittee, thank you for inviting me today to speak about our recent high-risk report, specifically about Medicare. We have continued to designate Medicare as a high-risk program because of its complexity and susceptibility to improper payments added to its size. This has led to serious management challenges. In 2010, Medicare covered 47 million elderly and disabled beneficiaries and had estimated outlays of $509 billion, making it the third largest federal program in terms of spending. Currently, Medicare remains on a path that is fiscally unsustainable in the long term. This heightens the urgency for the Centers for Medicare and Medicaid Services to address our recommendations, effectively implement new laws and guidance, and improve its management in 4 areas. Broadly, these areas include reforming and refining payments, improving program management, enhancing program integrity, and overseeing patient care and safety. Today, I'm going to focus my oral comments on payments and program integrity. With regard to reforming and refining payments, CMS has implemented payment reforms such as for Medicare Advantage, inpatient hospital, and home health services. It has also begun to provide feedback to physicians on their resource use, which is positive but which could benefit from additional refinement, and is developing a new payment system that accounts for the cost and quality of care. But more could be done. For example, we have recommended to CMS that they consider implementing more front-end approaches to controlling the growth of imaging services. In addition, we recently found that although payments for home oxygen have been reduced or limited several times in recent years, further savings are possible. In regard to program integrity, Congress recently passed laws including the Improper Payments Elimination and Recovery Act, the Patient Protection and Affordable Care Act, and the Small Business Job Act that provide authority and resources that impose new requirements designed to help CMS reduce improper payments. The administration has also issued executive memorandum, including one that requires agencies to check certain databases, known as the Do Not Pay list, before making payments to ensure that payments are not made to individuals who are dead or entities that have been excluded from federal programs. CMS is taking steps to implement these laws and memoranda through regulations and other agency actions. In 2010, it created a new Center for Medicare and Medicaid Program Integrity to better coordinate efforts to prevent improper payments. CMS has been tracking its improper payment rates in Medicare Fee-for-Service and Medicare Part C, and has established performance goals for reducing those rates in the future. However, the agency has not yet reported a single error rate for Part D and has not been able to demonstrate sustained progress in lowering its improper payment rates, so continued oversight is warranted. Having a corrective action process in place to address vulnerabilities that lead to improper payments is also important to managing them effectively. Our work on recovery auditing, which reimburses contractors on a contingency basis to uncover payments that should not have been made, found that CMS had not developed an adequate process to address the vulnerabilities that had been identified by the contractors. Since it is important to address these issues going forward, we recommended that CMS develop a robust corrective action process. Further, we issued a report in February 2009 that indicated that Medicare continued to pay some home health agencies for services that were not medically necessary or were not rendered. To address this, we made several recommendations, including that CMS direct its contractors to conduct post-payment reviews on home health agencies with high rates of improper payments. CMS has not implemented this and several other recommendations to improve its program safeguards. In conclusion, although CMS has taken many actions to improve the integrity of the Medicare program, further action is needed to ensure that payments are proper and vulnerabilities to improper payments are addressed. We are beginning new work to address some of these issues to determine if additional agency or congressional action might be helpful. Mr. Chairman, this concludes my statement. I'd be happy to answer any questions.
Thank you. Mr. Roy?
Good morning, Chairman Stearns, Ranking Member DeGette, and distinguished members of the subcommittee. I am Gerald Roy, Deputy Inspector General for Investigations at the U.S. Department of Health and Human Services, Office of Inspector General. Today I'm privileged to have with me OIG Assistant Special Agent in Charge Omar Perez of our Miami Regional Office. OIG is an independent, nonpartisan agency committed to protecting the integrity of more than 300 programs administered by HHS. The Office of Investigations employs over 450 highly skilled special agents who utilize state-of-the-art investigative technologies and a wide range of law enforcement actions, including the execution of search and arrest warrants. We are the nation's premier healthcare fraud law enforcement agency. Our constituents are the American people, and we work hard to ensure their money is not stolen or misspent. Over the past fiscal year, OIG investigations have resulted in over 900 criminal convictions and civil actions and over $3.7 billion in recoveries. Today I will discuss three critical aspects of OIG's work: the Medicare Fraud Strike Force model, corporate fraud investigations, and tools employed by OIG. The Medicare Fraud Strike Force model is a critical component of one of the administration's signature initiatives known as HEAT. This is a joint effort by HHS and DOJ to leverage resources and expertise to prevent fraud and abuse. Strike forces concentrate anti-fraud efforts in geographic areas at high risk for fraud. Strike force teams consisting of OIG agents and our law enforcement partners are assigned to dedicated prosecutors. Strike force cases are data-driven, which allows us to catch criminals in the act. We operate in 9 locations, and we plan to expand to other high-fraud areas. Last month, Heat Strike forces engaged in the largest federal health care fraud takedown in our history, arresting over 100 defendants in 9 cities associated with more than $225 million in fraud. More than 300 OIG special agents led this operation. The photos you see here today show our special agents engaged in search and arrest activities. We are also aggressively pursuing major corporations and institutions that commit healthcare fraud on a grand scale. Corporate fraud often involves complex kickbacks, accounting, and illegal marketing schemes. Some of these companies play such a critical role in the healthcare delivery system that they may believe that the OIG would never exclude them. Some executives consider civil penalties and criminal fines just the cost of doing business. As long as the profit from fraud outweighs the cost, abusive corporate behavior will continue. OIG plans to alter this cost-benefit calculus of executives by more broadly employing one of the most powerful tools in our arsenal: the authority to exclude individuals and entities from participating in federal health care programs. When there is evidence that an executive knew or should have known of the underlying criminal misconduct of the organization, OIG plans to exclude that executive from our programs. Recently, we assigned a special agent to the International Criminal Police Organization, Interpol. Interpol facilitates international investigative cooperation between 188 member countries and more than 18,000 law enforcement agencies in the United States. HHS-OIG is the first in the Inspector General community to have a special agent assigned to Interpol. We have over 170 fugitives running from healthcare fraud charges. We will leverage the resources of Interpol's worldwide partners to bring them to justice. In February, OIG launched our most wanted fugitive website. The individuals you see on our top 10 fugitive poster allegedly defrauded taxpayers of more than $136 million. We have partnered with America's Most Wanted and Interpol to feature our website and actively spread the word. We are asking the public to help us bring these fugitives to justice. The bottom line, we are sending a clear message that fraud will not be tolerated. And our success represents a prudent investment of taxpayer dollars. For every $1 spent on our healthcare fraud programs, we return over $6 to the Medicare Trust Fund. Thank you for the opportunity to discuss our law enforcement efforts and strategies. We are committed to serving and protecting the nation's most vulnerable citizens and the federal health care programs on which they rely.
Thank you. Mr. Perez, welcome.
Good morning, Chairman Stearns, Ranking Member DeGette, and distinguished members of the subcommittee. I'm Omar Perez, Assistant Special Agent in charge with Health and Human Services Office of Inspector General. I'm stationed in Miami and currently supervise agents assigned to the Medicare Strike Force. And prior to assuming my position, I was a member of one of the Strike Force teams. I'm honored for the invitation and opportunity to discuss our efforts in combating healthcare fraud. This morning, I'm here to tell you what our agents and I experience as criminal investigators on the front line in this fight against healthcare fraud. Although the vast majority of Medicare providers are honest, my job and our job is to focus on those intended on stealing from the program. My squad is actively engaged in criminal investigations, testifying before grand juries, executing search and arrest warrants, and seizing bank accounts. Now, Medicare fraud is discussed openly on the streets of South Florida because it's accepted as a safe and easy way to get rich quick. Now, the money involved is staggering. We see high school dropouts making anywhere from $100,000 to millions a year. Typically, we see business owners, healthcare providers, doctors, and Medicare patients participate in the fraud. But now, we see drug dealers and organized criminal enterprises joining in. Today, I'll describe the typical fraud scheme, highlight Miami's investigative model, share success stories, and finally discuss the evolution of fraud in South Florida. Now, prior to the start of the strike force, Miami was riddled with sham DME companies whose owners had one idea in mind: steal from the program. In order to perpetrate the fraud, nominee owners were recruited to place their names on corporate documents, lease agreement, and corporate bank accounts, and in exchange were paid between $10,000 to $20,000. Stolen patient information was obtained from corrupt employees at hospitals, clinics, and doctors' offices. They also obtained lists of stolen physician identifiers, and with these two key pieces of information, submitted fraudulent claims to Medicare for equipment that was never provided. Once the money was deposited into the account, it was withdrawn within days. The idea was to deplete the account so that by the time Medicare even realized that there was a fraud, there was no money left to recover. These schemes are executed within a matter of months, so we developed a streamlined investigative approach to HEAT investigations. The model includes the following steps to help identify our targets: quickly obtain and analyze Medicare claims, identify and obtain banking information, obtain the corporate documents, and identify the medical billing agent. Now, the following examples highlight the successes of our model. 2 months ago, one of our agents received information from a confidential source that a DME company was submitting fraudulent claims. Through data analysis, we saw that $1.5 million was billed in just 3 weeks after a corporate change of ownership. Further data analysis shows that this company and another that we had under investigation was billing for about the same 100 patients. So within 30 days, The agents corroborated that fraud was taking place, and we were able to arrest the target. Using this model, he got zero money. When we arrested him, we found a fake driver's license and learned that he was about to purchase yet another company under this assumed identity. In another example, a source alleged a corporation owning several community mental health centers was paying patients to allow them to bill for services they were not receiving. Data analysis and other investigative techniques led to 5 individuals being indicted and arrested and 7 search warrants being executed simultaneously. Now, 2 weeks ago, we indicted and arrested another 20 individuals associated with this corrupt corporation. And those arrested included center directors, physicians, therapists, patient recruiters, and money launderers. The photographs you see are of the lavish estate of a patient recruiter who also laundered money for the corrupt corporation. We're finding that criminals have migrated to other services within the Medicare program, including home health, community mental health centers, physical and occupational therapy. Historically, Medicare patients and doctors were not involved, but now we're finding that in many cases both are getting paid to participate in the fraud. Additionally, not only are we seeing criminals migrate to other parts of the state, but we know that they've migrated to states adjacent to Florida and other parts of the country, like Georgia, North Carolina, Tennessee, West Virginia, and Michigan. Thank you very much for the opportunity to discuss the strike force operations in South Florida and the investigative model that we utilize to protect the taxpayers' interests, and I certainly welcome the opportunity to address any questions the panel has.
Thank you, Mr. Perez. Mr. Spiegel.
Thank you. Chairman Stearns, Ranking Member DeGette, and members of the subcommittee, thank you very much for the invitation to discuss the Centers for Medicare and Medicaid Services efforts to reduce fraud, waste, and abuse in the Medicare, Medicaid, and children's health insurance programs, and the new tools and authorities provided in the Affordable Care Act. I'm happy to be here today, appearing on behalf of Peter Bedetti, who's the director of the Center for Program Integrity, where I work as the director of the Medicare Program Integrity Group. Dr. Bedetti said from the beginning of the time on his job that people asked him 2 questions repeatedly. Why do you let the crooks into Medicare and Medicaid, and why do you continue to pay fraudulent claims? Well, I can tell you that with the new authorities provided in the recent laws and the commitment of the administration in fighting fraud, we're making progress on both fronts. Our approach will be keeping people who don't belong in the programs out, and will be kicking out fraudulent claims before they're paid. We now have the flexibility to tailor resources to address the most serious problems and quickly initiate activities in a transformative way. Under the leadership of Secretary Sebelius, CMS has taken a number of administrative steps to better meet emerging needs and challenges in fighting fraud and abuse. For example, CMS consolidated the Medicare and Medicaid program integrity groups under a unified Center for Program Integrity to pursue a more strategic and coordinated set of program integrity policies and activities across both programs. This change in structure and focus served our program integrities well and has facilitated collaboration on anti-fraud initiatives with our law enforcement partners in the HHS Office of Inspector General and in the Department of Justice, and state Medicaid fraud control units as well. And just last week, we restructured the center to provide some additional concentrated focus on the new initiatives that I'll be talking about in a little bit. Some examples being increased focus on data development and uses of analytics that will help bolster our work. And the Affordable Care Act enhanced this organizational change by providing an opportunity to develop policies across all of our programs jointly. The Act's provisions such as enhanced screening requirements for new providers and suppliers apply across all the programs, not just for Medicare or not just for Medicaid, and they're uniform across the board. This ensures consistency, obviously, is one of the goals that we've tried to pursue in our fraud and abuse activities. So many might argue that just rearranging the boxes doesn't have much of a value, but we think that having created a Center for Program Integrity that's on a par with other major operating components within CMS sends a powerful message about the administration's serious commitment to fighting fraud, and it puts the bad actors on notice. And because most success in anything comes from clarity of purpose, we've made certain that our sights are firmly fixed on the goal of ensuring that correct payments are made to legitimate providers for covered, reasonable, and appropriate services for eligible beneficiaries. I'd like to take a little time today to explain how we've been transforming our fraud detection and prevention work through the new approach shown on the poster. I'll try not to poke you over there. So first, central to our goal is a shift away from identifying fraud before it happens. We want to prevent things from taking shape. We want to move away from pay and chase that we've relied on so heavily in the past. Second, we don't want to be limited to a monolithic approach to fighting fraud. Instead, we want to focus our efforts on the bad actors who pose elevated risk. Third, we're taking advantage of innovation and technology as we move quickly to take action focused on prevention when possible. And fourth, consistent with the administration's commitment to being transparent, we're developing performance measures that will specify our targets for improvement. Fifth, we're actively engaging public and private partners from across the spectrum because there's obviously much to learn from others who engaged in the same endeavor of fighting fraud. We know the private sector is victimized by the same schemes we see in public programs, and collaboration and communication among all parties, we think, will further enhance our fraud fighting on our efforts as well as in the private sector. And sixth, finally, we're committed to coordination and integration of our activities across all the programs in CMS based on best practices and lessons learned. So as we move away from the old ways to more modern and sophisticated and successful approaches, we're continuing to concentrate our actions so that we...
Just if you can sum up, your time's over.
Okay, sorry.
Thank you.
Let me just get through this one particular part and I'll be finished.
Can you just summarize?
30 seconds. Sure. We want to do a better job of keeping people out before they get in. We want to move quickly when we see those who have gotten in that are potentially making improper bills and take steps to reduce claims payment error by 50% and get people out who don't belong there.
Thank you. Thank you. With that, I'll open up with questions. Let me start with you, Mr. Spiegel. When I looked at your resume, it looks like you've been on the job less than a year. You started in June 2010. So you've really been the man who's director of Medicare Program Integrity for less than 1 year. Is that correct?
That's correct.
And you came from the private sector?
Most immediately.
Okay. You might not have a handle on this, but how much money, in your opinion, is lost to fraud each year in the Medicare program, precisely?
Well,
just precisely.
I'd have to answer that question and say that there is no actual one number.
So you don't know? Is that fair enough? Now, 60 Minutes in September had an expose on Medicare, and they indicated it was $60 billion. And they had one witness indicate it would be $90 billion. Do you think it's fair to say that it's anywhere from $60 billion to $90 billion, based upon what 60 Minutes said?
Like all of us, I've heard the estimates that have come from private groups as well as government.
Why is it so difficult to understand what the figure is? If 60 Minutes has come up with it, witnesses have come up with it, we had the Justice Department give an estimate, why isn't that you're the man in charge of Medicare program integrity? Why can't you give us an estimate of what it is, approximately?
Well, because a lot of the estimates that you cite and others cite contain information that deals with things that aren't necessarily fraud. Some of them turn out to be improper payments, things we want to know about, but they're really not fraud, and it's not necessarily appropriate.
All right. Mr. Waxman indicated in his opening statement that these new requirements that are in the Obamacare prevention will save us $7 billion a year. Do you think that's an accurate statement?
I believe Mr. Waxman cited CBO estimates.
Okay. Now, the problem is it's a program, $650 billion, and they're saving $7 billion. That's probably about less than 1%. How can you effectuate eliminating waste, fraud, and abuse when you cut the program $550 billion like Obamacare does? So just a question for Ms. King. If you're actually cutting Medicare program, wouldn't that make it more difficult to prevent waste, fraud, and abuse just by axiomatic? Wouldn't it be self-evident that you can't cut a program that amount of money and still reduce waste, fraud, and abuse?
Mr. Chairman, I think that the reductions in Medicare spending are reductions off the rate of growth and not overall reductions in the size of the
Well, that's not how we understand it. But, Mr. Spiegel, let's go to Medicaid. How much is lost to Medicaid? Not Medicare, because you say you don't know. What about Medicaid? What's the loss to fraud?
Same issues that surround trying to come up with a number for fraud in Medicare.
So you have no idea, not even approximate. Okay. Now, Ms. King, they're expanding Medicaid by another 20 million people they're going to add. And so if you're going to expand it, increase it, and Medicaid has a lot of fraud, wouldn't that indicate that you're going to have increased fraud?
I think it depends on the what happens with the new authorities that CMS was given in the Affordable Care Act and how they're implemented.
Let me say, the Republicans on this side were very glad to vote for any legislative measure to prevent fraud. Anti-fraud measures we're glad to implement. It's just we're worried about some of the things I mentioned about. So, Mr. Spiegel, my concern is before we expand Medicare and Medicaid, we still don't know how much we lost to fraud. And you're the man at charge, less than a year. So you're saying at this point we just have no idea how much it's going to, how much fraud and waste and abuse. So it seems to me that if you don't even have a handle on what the amount is, it's going to be very difficult to penetrate it down. Let me ask a question to Mr. Roy and Mr. Perez. I appreciate, Mr. Perez. I said in my opening statement, I just said that Medicare fraud is rapidly ellipsing the drug trade as Florida's most profitable and efficient criminal enterprise system. This was comments based upon the 60-minute expose. Do you think that's true?
Well, we certainly have seen in some of our investigations that individuals that used to participate in the drug trade are now certainly involved in healthcare fraud.
Have you seen a lot of organized crime involved in Medicare and Medicaid fraud? Mr. Roy?
Yes, sir. We're seeing.
Just bring the mic just a little closer to you, if you don't mind.
My apologies. We are seeing an uptick in organized crime elements engaging in healthcare fraud, whether it is structured organizations like Eurasian organized crime that we see out in Los Angeles, to more loose-knit organizations that we see in Texas and Miami, Florida area.
Mr. Roy, that's probably putting you on the spot, but do you or Mr. Perez and your colleagues and your talking, have you come up with what is a figure of how much fraud would you venture against?
No, sir, I cannot.
Would you venture against it's more than $7 billion a year?
Yes, sir, I would.
And Mr. Perez, would you venture a guess that the fraud in Medicare is more than $7 billion a year?
I know we recovered $3.7 billion, so certainly I think.
So what I'm trying to say, Mr. Spiegel, is here you have no idea what the fraud figure is, and the people to your right, the two of them have indicated, and one has indicated that he has found just in Florida $3.5 billion. So you have, it's just incomprehensible to me how you can come here this morning and say you have no idea how much the fraud when the man to your right has indicated that he can track $3.5 billion himself. And so I think when Mr. Waxman mentioned $7 billion, that's just the tip of the bucket. That's just the tip. And there's so much more there, and I think Mr. Roy and Mr. Perez have confirmed that. My time has expired. I let the ranking member, Mr. Gett.
Thank you so much, Mr. Chairman. Well, let me follow up on that, Mr. Spiegel, with you. I believe the CBO estimated that the provisions of the Affordable Care Act will save the taxpayer $7 billion over the next 10 years. Is that correct?
I believe that's what he said. Yes.
Is that the only money that the administration intends to save on fraud in Medicare and Medicaid?
No.
Could you explain, please, why that's not the? I don't want this to be misinterpreted that the administration that these are the only efforts that are going to be made. What other efforts are being undertaken to eliminate fraud, waste, and abuse?
Well,
briefly.
Thank you. First of all, however much the number is for fraud that's going on is too much.
Right. What other efforts are being undertaken to avoid fraud, waste, and abuse? Briefly.
Okay. So we are implementing the new provisions of the Affordable Care Act that allow us to do a better job.
Okay. What other? Oh, Mr. Perez, do you have an answer? Oh, you're just trying to move the mic.
Sorry.
Mr.
I mean,
what I'm saying is the provisions of the Affordable Care Act are not the only provisions of law that help us to avoid waste, fraud, and abuse. What other provisions in law that may be separate and apart from the $7 billion are going to help us avoid fraud, waste, and abuse?
Okay, so in addition to the things that I was talking about with regard to provider screening, we have a whole range of activities that we do now and that we're continuing to do to oversee proper payments.
Okay, so if you can supplement your answer in writing, that would be helpful.
I would be glad to do that.
In essence, what you're saying is the $7 billion is in addition to efforts that are being currently made.
That's right.
Now, Mr. Perez, the efforts that you're undertaking, those are being undertaken under those were being undertaken under current law, right? Because the Affordable Care Act hadn't been implemented yet, correct?
Yes, ma'am.
Okay. Now, Mr. Spiegel, perhaps you can talk about the enrollment screening requirements in the Affordable Care Act. Will they work to prevent enrollment by fraudulent providers?
Yes.
And how are they different than previous requirements?
Well, the new enrollment screening provisions allow us to focus on providers based on the risk that they pose. Excuse me. The risk of fraud that they propose. We have new and enhanced screening that we'd be applying to those that pose the greatest risk, like criminal background checks, database checks, fingerprinting for those that are posing the greatest risk. We have new approaches to consolidating our data and sharing data across Medicare and Medicaid so that both programs have access to information about for example, providers that have been terminated from Medicaid that may be terminated from Medicare as well, and vice versa. The particular provision one of the particular provisions in the provider screening rule we just published that may have the most effect is the Secretary's authority to impose temporary enrollment moratoria when she determines that there's a need to do that to combat fraud, waste, and abuse.
King, do you believe that some of these new provisions that we have talked about today will add to our arsenal in being able to target waste, fraud, and abuse and to eliminate it?
Yes, we do. We have previously identified several areas where increased enforcement and action would be helpful. One of those is enrollment. One of them is in prepayment edits. One is in post-payment edits. Contractor oversight, and the last is a robust process for corrective action. And the Affordable Care Act has provisions in several of these areas designed to enhance CMS's ability. And some of the key ones I think are on the enrollment side, because preventing fraud is a lot better and easier than chasing after it once it's been committed.
And these are new tools.
Yes, they are.
But would you agree that some of the existing tools that CMS has could also be used in a robust way?
Yes.
Okay.
Congress, starting in 1997 in HIPAA, created a program, a Medicare integrity program that was designed to focus on reducing improper payments and fraud and abuse. And that is what some of these activities that have been discussed today are funded from.
Thank you very
before
much.
the Affordable Care Act.
Thank you. I yield back.
Gentleman's time has expired. The gentleman from Texas, Mr. Barton, is recognized for 5 minutes.
Well, thank you, Mr. Chairman. Let's start off by saying that everybody on the dais here is anti-fraud and abuse. John Dingell is anti-fraud and abuse. Jan Schakowsky is anti-fraud and abuse. Diane DeGette is anti-fraud and abuse. The chairman is anti-fraud and abuse. All of our freshmen down here on the front row are anti-fraud and abuse on the Republican side. Dr. Murphy is anti-fraud and abuse. I mean, we are all anti-fraud and abuse. So this is not a partisan issue. But we are very frustrated. I've chaired hearings on this. John Dingell has chaired hearings on this. Diane DeGette has chaired hearings on this. Waxman has chaired hearings on this. I mean, it is so frustrating that we all agree it's a problem. We all want to solve the problem, and yet we still don't even know the scope of the problem. Now, why is that important? I believe that if you don't know what the problem is, you can't set goals on how to solve it. So let's say it's a 10% problem, which would be $80 billion. Maybe a reasonable goal then would be to cut that by 25% in a given year, which would be, what, $16 billion or $20 billion. Maybe it's only a $40 billion problem a year. But if you guys can't help us determine what the problem is, it's hard for us to decide how to set goals to solve it. So I'm going to go through a series of questions here, and they're kind of sophomore one-on-one questions. I'm not, and hopefully you've got great answers to every one of them. My first question is, and I'm going to ask Mr. Perez, because you seem to be the guy at the table that actually can do something about it, not just study it or whatever, but you can actually make things happen. Do you have the ability to seize assets of folks that you arrest and accuse of Medicare, Medicaid fraud?
Well, first, Congressman, thank you very much for the vote of confidence. I certainly appreciate that. And the department does not have, or OIG does not have seizure authority, but we do work in tandem with the Federal Bureau of Investigation or other entities that do have the seizure authority. And
does
so
anybody within HHS have the ability to go out and actually seize a physical asset, seize cash, seize equipment? Or do you have to go to the FBI to do that?
Currently, we have to use the FBI unless it's a civil proceeding.
Would you like to have the authority? Would Congress give you the authority to seize assets?
Sir, if I could respond to that. We would be more than happy to have that authority, but you have to understand that the size of our organization. Taking on full seizure authority entails taking on a tremendous amount of additional assets to be able to seize that and care for that property and then liquidate that property. It's a tremendous undertaking that is probably...
Right now, I just want to know if you want to have the authority. Mr. Perez seems to think he'd like it. You seem to think it's more trouble than it's worth.
Well, Mr. Perez and I are in lockstep here. We will take any additional authority that comes our way and utilize. And
I only have another minute and 25 seconds. Are there currently, under existing programs, taxpayer hotlines where people that can phone in or mail in or internet in tips on people they think are defrauding the government on billing claims? Do you have that?
Yes, sir. OIG has 1-800 Medicare, 1-800 HHS tips as our hotline.
What about my friend here, Mr. Spiegel? Do you have those sort of hotlines?
We do. We have 1-800 Medicare. We have special hotlines in South Florida.
Do you pay bonuses or some sort of a cash payment if the tip is followed up and actually proves to be correct?
We have a set of rules around that, and yes, we have.
How often is that used?
It depends. Well, there's a number of criteria that define it. It hasn't been used all that often, but it has been used recently, actually.
Do you have within your agency the ability to check internally for people that are employees that are part of scams in terms of credentialing people that shouldn't be, or checking for folks that are paying bills that they shouldn't pay? Is there an internal ability to check within the system?
There's a number of contracting requirements that are in place to make sure that the people who actually make decisions on our behalf are following the rules.
If it's not proprietary, and my last question, if it's not proprietary, how often does that type of investigation actually produce fraudulent activity within the system? In other words, 10% of the time that you check, or?
I don't know the exact number. I'd be glad to get back to you with that, though.
Okay. Thank you, Mr. Chairman, and I'll have some.
Thank you, and recognize the Chairman Emeritus, Mr. Dingell from Michigan. Recognized for 5 minutes.
Mr. Chairman, I thank you and commend you for this hearing. It's a very important matter. And I would note I was one of the people who went with our very fine investigators when they were conducting the 9 community raids on these malefactors that we're discussing today. And I want to commend you down there for the work that you're doing on this matter. I also want to commend the people from the Inspector General's office, from the attorney, from the GAO, and our friend Dr. Spiegel. I would like to observe one thing very quickly. No environmental impact statements are filed by these criminals, and they don't file any 10Ks or 10Qs so we can know what they're up to. And I want to say, Mr. Chairman, I commend you for having this hearing, because moving this process forward is extremely important. And there is a lot of money in the recent health care reform legislation which will make available to us the ability to make significant savings. I'm not about to criticize our witnesses today or anybody else for not having the costs of these things. These criminals don't operate by the clear light of day. These questions to Dr. Spiegel and to Ms. King. Dr. Spiegel and Ms. King, do you believe that the new tools included in the Affordable Care Act will help CMS to meet its goal? Yes or no?
Yes, if they're implemented properly.
Yes.
All right. Again, if you please. Funding for the health care abuse and fraud and abuse control program includes mandatory and discretionary funding. It's divided between CMS's integrity programs and law enforcement programs at the Office of the Inspector General and DOJ. The President's 2012 discretionary request is $581 million. If this funding is not provided, will CMS be able to hire the personnel necessary to implement the anti-fraud provisions included in the Affordable Care Act? Yes or no?
Until we find out exactly how much would in fact be appropriated, we won't know exactly what we'd be able to do, but we know that we're limited in our ability to plan right now.
But if you don't get the money, you can't plan and you can't hire,
and
we
wouldn't be able to hire
work.
We'd have to ratchet back.
All right. Now, the Affordable Care Act requires high-risk providers and suppliers who want to enroll in Medicare, Medicaid, or CHIP to undergo a higher level of screening. This increased scrutiny will be critical in rooting out fraud, waste, and abuse in susceptible programs. If the requested discretionary funding is not provided, will CBS be able to fully implement and utilize enhanced screening? Yes or no?
Again, it would depend on the levels of funding that ended up.
Simple fact of the matter is, if you don't get that, you aren't going to be able to move forward. You aren't going to be able to move forward until you know, and you aren't that you're going to get it. And until you get it, you aren't going to be able to do the hiring or the other things that are necessary to bring your enforcement program up to date. Isn't that right?
It would have severe effect on that, yes.
Very good. Now, again, Dr. Spiegel, the Affordable Care Act requires data sharing among federal agencies to monitor and assess risk levels in program areas and improve identification of fraud. If the requested discretionary funding is not provided, will CMS be able to implement full data sharing technology needed to coordinate monitoring and identifying sources of fraud across the federal agencies? Yes or no?
No.
Now, again, Doctor, the goal of the anti-fraud provisions in the Affordable Care Act is to move CMS away from that wonderful practice of pay and chase and preventing improper payments from happening in the beginning. While some improper payments may be due to honest mistakes, many criminals have made Medicare and Medicaid their targets, and also the other programs of this character. CMS has already begun testing risk scoring technology to predict and prevent fraud. If the requested discretionary funding is not provided, will CMS be able to fully test and pursue the technology? Yes or no?
No.
This to Deputy Inspector General Roy. This last summer, as I had mentioned, I was fortunate enough to attend a ride along with the Detroit Medicare Fraud Strike Force. That's 9 communities. And I saw some of the most extraordinary practices by the criminals in making money at the expense of Medicare that you could ever believe possible. And so as the first member to ever join Medicare Fund Trust Strike Force on Ride Along, I have enormous respect for the fine work that the strike forces are doing. They have the difficult task of not only rooting out fraud in our health system, but protecting our neediest populations, the poor, the elderly, and the sick, from the criminals seeking to make money from the most vulnerable. Do you believe that the Medicare strike forces have the staffing resources they need to be effective? Yes or no?
Yes, I do.
You believe they do now?
Sir, right now in the cities we're operating, yes. If we want to expand, I will need additional funding.
So your answer is that they don't have the resources, and you're hoping to get them for them. Is that right?
Absolutely.
Okay. Now, do you agree on that, Ms. King?
I don't have the basis of evidence to answer that question.
All right. Any other witness like to make a comment on that? Very well. This goes to you again, Inspector General Roy. If the requested discretionary funding for the Healthcare Fraud and Abuse Control Program is not provided, will the Healthcare Fraud Prevention and Enforcement Action Team be able to expand the Medicare strike force?
No, sir.
Yes or no?
No, sir.
All right. Now, I guess that completes my time, and I thank you for your kindness and generosity, Mr. Chairman.
I thank the gentleman. Mr. Burgess, gentleman from Texas, recognized for 5 minutes.
Thank you, Mr. Chairman and Mr. Spiegel. So I don't get lost in all the numbers that we're hearing this morning, let me walk through some things and you tell me if the thinking is generally correct. Now, if I understand correctly, the Congressional Budget Office scored for the entirety of the Patient Protection Affordable Care Act that the provisions in that act would save about $8 billion over the 10-year budgetary cycle. Is that correct?
That's my understanding.
And the HHS estimate of the error rate in the payment error rate is just under 10% at 9.4% a year. Is that correct?
Yes.
Now, Medicaid expenditures are going to increase of necessity under the Patient Protection Affordable Care Act. The number I calculate for that is about $430 billion over 10 years. Does that sound about right?
I'm not an expert on the Medicaid budget.
Does GAO have an opinion on the amount that we're going to spend additionally in Medicaid over the life cycle of the 10-year budgetary window?
I actually don't have that number off the top either.
Well, it is.
But it
is
like
part of a GAO
ballpark
report that we have that the cost of Medicaid expansion is estimated to exceed $430 billion over the next 10 years. So I'm going to assume the answer from GAO is yes. So just in Medicaid, just in the expansion of the Medicaid system that we're doing, we have an error rate that will lose $43 billion over the 10-year budgetary cycle, but we have safeguards in the Act that are going to save us $8 billion. So that's we're not netting out very much in that exchange, are we? And that's your division of CMS, right? I mean, that's what you're going to fix, right?
The part that I'm in the Medicare Program Integrity Group, and yes, we're focused keenly on preventing fraud, waste, and abuse in our program.
But in fact, the numbers just don't add up. I mean, this is going to cost us a tremendous. I'm all for the anti-fraud provisions that are in the Patient Protection Affordable Care Act, but there's no way in the world they're going to pay for the expansion that is occurring even just in the Medicaid part of this, let alone other areas. In my area in Dallas-Fort Worth, we've got a very aggressive, and Mr. Roy, Mr. Perez, I'm basically directing this question to you. We've got a very aggressive investigative reporter. She's very, very good. Becky Oliver is her name, and you just never know when she's going to walk up behind you and put a microphone 2 centimeters away from your face and ask a very, very tough question. And most of those tough questions have to do with Medicare and Medicaid fraud. And I referenced some of that in my opening statement. It almost seems as if organized crime and organizations from outside the continental United States, offshore organizations, are getting involved. This business is so lucrative and so easy, and the risks are so slight that they are really going after this money aggressively. And she was the one that pointed out to me that there was a Nigerian national who had several home health agencies opened under various provider numbers and a single post office box. I guess she wants to be cost effective, so she wasn't spending much on overhead. A single post office box, and yet the payment after one of her provider numbers was busted, the CMS keeps sending payments to the same post office box. I mean, you say you're doing stuff with the electronics and getting better at this, but oh my God, that's the sort of stuff the American people look at and they just don't understand. Is there a way to get at that?
Well, first and foremost, that is the scheme, to have multiple provider numbers and set those up.
So you know that, right?
Yes, sir. We are addressing it. In your city of Dallas, that is our brand new strike force city, and we are bringing the resources to there to adopt that model to address this issue.
I'm going to run out of time. Let me just add, I referenced in my opening statement about the prosecutorial force. You guys are doing the job we've asked you to do, and we're grateful for that. But when you bring these folks to light, are we able to actually get justice on these criminals, or do they end up back out on the street to sin again?
Now more than ever, I am seeing sentences and people go to jail that is more than I've seen before in the past. People are being prosecuted. They're going to federal prison for stealing from Medicare.
How comfortable are you with the prosecutorial manpower, the strength of the prosecutorial force that's available to prosecute this?
Getting better all the time. In your particular city, the resources coming from the Department of Justice are some of the best healthcare fraud prosecutors in our country.
Well, I appreciate that, and of course I've had several meetings with HHS and the Department of Justice on this issue after being asked the tough questions by Becky Oliver, so I credit her with having put some pressure on that. But I got to tell you, we've got to do a lot more in this. It is going to overwhelm the system. Yep. Thank you, Mr. Chairman. I'll yield back.
Thank you, gentlemen. Ms. Schakowsky from Illinois is recognized for 5 minutes.
Thank you. Do you have a strike force in Chicago, Mr. Roy?
Yes, ma'am, we do.
Can I go on a ride-along?
Yes, ma'am, you can.
Thank you. The Affordable Care Act increased mandatory funding for the Health Care Fraud and Abuse Control Fund by about $350 million, and index funding for the Health Care Fraud and Abuse Control Funds and the Medicare and Medicaid integrity programs to make sure that funds keep up with inflation. Overall funding to fight fraud will increase by about $500 million over the next 5 years. Mr. Roy, the House Republicans voted to repeal the health care reform bill, and that would cut off the funds the law provided for anti-fraud activities. So I do want to ask you, Mr. Roy, could you describe the impact of cutting off this funding and what it would do to anti-fraud initiatives that the administration is implementing under the Affordable Care Act?
Well, right now, as I stated, we are from the perspective of strike force, we are in 9 cities. I'd ultimately like to expand that using data to justify and find our hot spots. I will say that without additional funding at this point in time, I don't think I'm going to be in a position to open up additional strike force locations. I need the resources, I need the additional bodies to put in fraud hotspots across the country.
Thank you. Mr. Spiegel, would you want to answer that?
Sure. I mean, we had planned to expand the strike force locations from where they were to a total of 20, and because they're so effective in what they do, and we're obviously not going to be able to go there without the adequate resources to do that.
Thank you. Ms. King, the Affordable Care Act includes provisions to provide more transparency in nursing home ownership and operating structures and to require training, compliance, and ethics. Ensuring that we have complete and accurate information on ownership allows not just more transparency, but provides tools to allow regulators to hold any wrongdoers accountable. How important is it to have this data in your view, or in GAO's view?
I think that we believe it's always important to have good data about the people who are participating in the program. so that you can track what's going on.
Mr. Roy, you had mentioned the importance in your written testimony, I didn't hear it orally necessarily, but of whistleblowers in identifying possible wrongdoing. Last month, a Florida long-term care ombudsman asked for information on nursing home structure, the same information that will be required in the Affordable Care Act, and was subsequently fired by Governor Scott. Without getting into the specifics of the case, do we need to provide whistleblower protections for long-term care ombudsmen and others who seek information about fraud and abuse? And in the nursing home area, do we need to look at special protections for long-term care ombudsmen?
Well, I'm certainly in favor of some type of protection for all our whistleblowers. I'm not familiar too in depth with the matter you're speaking about.
Mr. Perez, are you being in Florida? No? Okay. No? Okay. And so the protection for whistleblower, is that an important source for you?
It is, specifically with corporate fraud. Whistleblowers often file what we refer to as qui tam lawsuits, which are lawsuits on behalf of the federal government. They're usually corporate insiders with in-depth knowledge of corporate fraud. From a corporate standpoint, they are essential to our work.
And do we have those protections, or in the new act, are we going to do better to make sure we protect those people?
In the new act, I do not say, I'm not familiar with anything that would point toward whistleblower protection, but I'm certainly not an expert on everything in that Affordable Care Act.
Okay, thank you very much. I yield back.
Gentleman from Nebraska, Mr. Terry, is recognized for 5 minutes.
Thank you, Mr. Chairman. I like the strike force or heat. That seems to be a common theme on both sides of the aisle. Probably here because it's positive news of success. I'm trying to get my arms around what resources CMS has right now to fight fraud and abuse. Under the PPACA, I understand there'll be an additional $35 million per year, as Dr. Burgess said. That won't even come close to what will fraud and abuse from the expansion of Medicare. But that's the CBO number. I don't know what the base is right now. What does CMS set aside per year for investigating and prosecuting fraud and abuse? Do you know that number?
I don't know right offhand, but the investigating and the prosecuting takes place to my right.
All right.
But the identification and the looking for and the dealing with improper payments and fraud at the front end would be us. And it's
Will you please provide that number to the committee, please? And why I wanted that is so I can get a picture of what percentage of your budget is being used for policing purposes. And then I would like the opportunity to compare that to private sector health insurance, who seems to be able to do a lot better job in weeding out, finding insurance fraud and abuse, and what they spend in policing. I think that's a good opportunity to figure out if you have enough resources or not. Obviously, I'd say you don't have enough resources.
Well, one of the things about the way the private sector does things versus the way we do it is they have a different...
I didn't ask that, and I only have 2 minutes.
Sorry.
But I am curious about it. But let me talk to Mr. Roy. With your strike forces and the work with justice in being able to prosecute these, if you had the perfect world and Congress came to you and CMS came to you and said, what do you need to get $50 billion a year recovered, what would you need?
it would have to be a joint effort between us and Department of Justice. I can hire as many agents as possible to address the fraud, but I also need prosecutors to prosecute that case. The perfect world is that we utilize the models we're using now, looking at data to find these hotspots and then have the ability to put agents in those particular hotspots and the prosecutors to prosecute the cases as well.
Would you be able to provide us information of if we set a goal of $50 billion per year, how many more? And by the way, I think it was the testimony, I don't know if it was you or Mr. Perez, said you already have 300 agents working in heat in these strike forces.
That was just the agents. I do not have 300 agents assigned to strike force locations. When we did that operation 2 weeks ago, I took 300 out of my 420 plus agents and detailed them, if they're not already on the ground, to the cities where we had strike force operations take place.
Can I assume that not all 420 of your agents are dedicated to fighting CMS fraud and abuse?
That's correct, sir. 80% of our time is spent in the realm of healthcare fraud, but we oversee the 300 plus programs of the department, and I'm certainly engaged in oversight activities, criminal activities, and those other departments as well.
We're, Mr. Perez, being on the streets and getting information, it sounds like fighting drug distribution on the streets. What do we need in communities and on the streets to be able to obtain this? The gentlelady from Illinois mentioned whistleblowers. I think that's probably an important part of this. How much of it, and how much of it come from just hearing it on the street?
I'm unable to quantify exactly how much we get from the street, but I think one of the things that, to underline your question, or at least answer it, is one of the things that I think we would like to see in the field, at least as agents, are two things. Is one, an ability to access the claims data directly. In other words, be able to have sit outside of a business who we believe fits all the mold of a fraudulently run company, and actually open up a laptop, log on, and actually to be able to see whether or not a claim is being submitted by that company now, whether or not there's any payments that are on the payment floor, if they've already submitted claims, and we can make phone calls and actually start doing the investigation from right outside of the parking lot. That would be
and that's not available to you today?
Not today.
All right. Thank you.
Gentleman from Texas, Mr. Gonzalez, recognized for 5 minutes.
Thank you very much, Mr. Chairman. And my question will be to I know GAO did a study on Medicare, and CMS estimated that it could be as much as $48 billion in improper payments. What I don't want to fall into here is equating fraud, waste, and abuse with an improper.
Does the gentleman have your speaker on?
Thank you very much, Mr. Chairman. I do not want to equate fraud, waste, and abuse to improper payment, which may be a billing error or a good faith mistake. So can you, taking that into consideration, and I think that Dr. Burgess asked if it was an accurate, I think he quoted a percentage of 10% of payments on Medicaid can be attributed to fraud. But that wouldn't be accurate. Is that correct? I think it was Mr. Roy and Mr. Spiegel may have responded to Dr. Burgess's question.
That's what you said is accurate. It's not fraud. It's improper payments. And it's important to make that distinction as we try and calculate what the elusive number is that everybody's going after. Some of the numbers tend to have a lot of improper payments or just billing errors or things that aren't anything more than a mistake included in them. They're not fraudulent, and so we're reluctant to say things like that. But the Medicaid number is improper payments.
Okay. Mr. Roy, obviously you're not going to go and prosecute and seek some sort of legal action against someone that it's a good faith mistake, yet that number is going to be taken into consideration when we're trying to look at payments, overpayments, and so on. What I'm saying is that it's not all criminal activity. so that when you take Jan out there in your car and you're making all the big busts, you're not going to be going to providers that has simply made a good faith mistake on a billing statement.
That is correct, sir. In the strike force model, for the most part, these providers that we're going after are involved in almost 100, or if not 100% fraud.
Because you have limited resources, I understand that, and you were going after the true wrongdoers and such. Because I think there are some participants out there that make a good faith mistake. I don't want to make excuses for anybody out there that is billing the government, again, fraudulently and so on, and no one is for that, and my colleague from Texas, Mr. Barton, pointed that out. What about the private sector? Let me ask Mr. Roy and even Ms. King, has there ever been a comparison, or Mr. Spiegel, as far as what is happening when it comes to fraud, waste, and abuse with the private sector? What is the percentage there that is being suffered as a result of the same actors or similar actions by individuals that are defrauding, obviously, the private sector? Do we have numbers there? Is there a percentage that we can estimate, guesstimate, as to how much is the private sector suffering as a result of fraud or criminal activity?
You know, to my knowledge, there is not a number out there about that. And one of the difficulties, I think, on fraud is that you don't know what you don't know. And part of the reason I think that Medicare doesn't know the number about fraud, or we don't know about that. If someone does something fraudulently, for example, they submit a claim on behalf of a beneficiary who's deceased, or they buy a beneficiary's number and they submit a clean claim, that claim is paid, and that's not going to show up as fraud or improper payments because it's slipped through the system. So that's part of the difficulty about estimating a number on fraud.
Now I appreciate that, whether it's in the private sector or public sector. You're still faced with the same dilemma. And I think that's important to point out, rather than saying that this is something distinct and unique to Medicaid or to Medicare. Mr. Roy, I'm just curious, and I've got about 32 seconds, but quickly, what is the state's obligation when it comes to Medicaid fraud? Because we had an incident in Texas, I don't know if you're familiar, that the governor did relieve the doctor that basically was managing, or the head of looking at the Medicaid contracts with providers, as well as the attorney that was charged with prosecuting. Are you familiar with that case?
No, sir. I believe this might be a question that's probably better posed to Mr. Spiegel than myself.
Mr. Spiegel, what is the role of the state governments?
Well, the state government has a responsibility to have a Medicaid fraud control unit, and they do, and they look at instances where they can take action to both identify and prevent fraud. There's data systems in place in most, and again, I'm not an expert on this, but there are data systems in place in all state Medicaid programs that allow a fairly robust analysis of things that appear to be aberrant or improper. They have.
Complete your answer.
You can complete your answer, Mr.
Okay,
Spiegel.
sorry. That similar to the way we do things in Medicare, where they make sure that they're paying for people who are properly enrolled in Medicaid in a proper amount for a provider that's eligible to provide the service.
Well, thank you, Mr. Spiegel. So that's a shared responsibility then.
Yes.
Thank you. Mr. Chairman, thank you for your
Thank you.
indulgence.
Mr. Gingrey from Georgia is recognized for 5 minutes.
Mr. Chairman, thank you. I want to go back to Ms. King and a follow-up on the question that Mr. Gonzalez from Texas just asked you, because I think it's a real important, pertinent question. Ms. King, you're director of the Healthcare Division of GAO, and if you don't have this information here today, you ought to be able to get it for the committee. And the question that he asked in regard to comparing the amount of waste, fraud, and abuse in the private sector versus the government sector, and primarily we're discussing Medicare and Medicaid, I think is of paramount importance. And I want, Mr. Chairman, to ask Ms. King, maybe she can answer that right now, and gladly give you the opportunity to do so.
You know, we'd be happy to look into it and see if we could get an answer to it, but as a practical matter, we don't have a right of information from the private sector, so we would have to ask them to provide that information to us, as opposed to on the government side where we have a right to information.
Well, yeah, and I appreciate that, and certainly I think that you ought to use every tool that you do have available to get that information, because quite honestly, a lot of us feel that the big government, and the bigger it gets, the more expansive it gets, and 15 million additional people on the Medicaid program, and we got 47 million now on the Medicare program that are aged and disabled, and that number is just going to grow as all the baby boomers are maturing. And you know, you expand this Obamacare program, another entitlement program. In fact, let me ask you a specific question about that. On July the 30th, 2009, President Obama stated that his health plan, that's why I referred to as Obamacare, was funded by eliminating the waste that is being paid out of the Medicare Trust Fund. And then on September 10th, 2009, Speaker Pelosi said that Congress will pay for half of Obamacare, $500 billion, by squeezing Medicare and Medicaid to wring out the waste, fraud, and abuse. And I'll ask you, indeed, Mr. Spiegel as well, was cutting $137 billion out of the Medicare Advantage program in any way, shape, or form cutting out waste, fraud, or abuse?
I don't have the exact numbers off the top of my head, but we and MedPAC have done work that has shown that payments to Medicare Advantage plans are higher than those that are made in fee-for-service.
Well, Ms. King, we know that. I mean, we understand that. It's 112%. That's not an arguable. The point is you overpaid them. That's not waste, fraud, and abuse. It may be waste, but it's certainly not fraud and abuse.
It's not fraud and abuse, but it could be considered waste by some.
Ms. Spiegel, any comment on that?
I'm just trying to identify and prevent fraud in my job. To respond to the questions about.
You're going too slow for me. I'm going to give you a pass. Let me go to Mr. Perez and Mr. Roy. Can you tell us what you've seen in terms of organized crime involvement in Medicare and Medicaid fraud? We see these post over there. I keep looking at it. It looks like Murderer's Row. But what's going on in Miami? And is organized crime involved heavily in Medicare and Medicaid fraud and abuse, and why?
I'll answer the first portion of that question about the overall scope of organized crime. Because it is geographical in nature. For instance, in the Los Angeles area, you are seeing very organized criminal structures, in essence Eurasian organized crime entities, heavily involved in Medicare fraud. They are involved in many street-level crimes as well. They're also involved in such as credit card fraud and identity theft. But what we are seeing is that in order to get to the upper echelons of these organized criminal elements, you have to go through healthcare fraud. That's where they make their money. And that is different from what we would see in Texas and in Miami. And with respect to what we see in Miami, I'll turn that over to Isaac Perez, and he'll give you an idea of what's going on there.
Mr. Perez, thank you.
Well, thank you for the question. A lot of the things that we are seeing are a group or groups of individuals that have tiers underneath them. And for all intents and purposes, there are even another subset of cells that work underneath that second tier, and one cell won't necessarily know what the other cell is doing, but they all kind of report to the same few folks in the top.
I see my time has expired, Mr. Chairman, and thank you, the panelists, for your response, and I yield back.
I thank the gentleman. Mr. Scalise, the gentleman is recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate the panelists for coming. We're talking about waste, fraud, and abuse. I want to first go back to something I saw in our state and ask you to comment on some of the things that we saw and how it's being dealt with at the federal level. In 96, when I started in our state legislature, we had our governor appointed a 24-year-old to run our health department. At the time, it was the largest department in state government. And there was a lot of waste, fraud, and abuse, and the governor made it a priority. And when we talk about zero tolerance against waste, fraud, and abuse, it's an attitude. It can't just be rhetoric. It's got to be followed by real action. And so the governor set out on a mission to root out that waste, fraud, and abuse. He appointed, as I said back in 96, a 24-year-old to run that department and to go and seek it out. And in fact, that new head of our department was very aggressive. People went to jail. They shut down programs. There were Medicaid mills. A lot of things that were going on that got rooted out. We cut out almost $1 billion in waste, fraud, and abuse in our department. I say that to make a point that that person that was 24 years old at the time is now called Governor Bobby Jindal. He's now the governor of our state. But he was very aggressive then as the head of our Department of Health and Hospitals in rooting out that waste, fraud, and abuse, and he's still aggressive today. I want to know, what coordination do y'all have with our governors who are aggressive in rooting out, whether you find Medicare fraud or Medicaid fraud? If you're finding Medicare fraud by a provider that's maybe doing business in other states in Medicaid, how much do you coordinate those things with the states who are specifically dealing with Medicaid, because they do have real jurisdiction there? I'll let y'all kind of go down the list. Ms. King.
Sorry. There's one provision in the Affordable Care Act that gives CMS the authority to revoke Medicare enrollment if Medicaid enrollment has been revoked in a state. So if someone has a bad actor in Medicaid and they're excluded from Medicaid, Medicare can follow the lead on that, and that's a new authority.
And that's addressed in our most recently published final rule with the new screening authorities.
Do you coordinate with the governors when you do find, let's say you find Medicare fraud, or even you're working on Medicaid fraud? Are y'all coordinating with those governors in those states who maybe have some some enforcement that they're trying to do on their as well?
Sir, from a law enforcement perspective, we are working very closely with our Medicaid fraud control units, which obviously the governor would be their representative from the fraud level. We're doing great work there. Over the last 3 years, we've probably increased our joint cases with the Medicaid fraud control units by upwards of 25%.
Okay, thanks. And I need to move because we're limited on time. I apologize. One of the components we really haven't talked about a lot is the waste component of waste, fraud, and abuse. And when you talk to doctors, and I've talked to a lot of doctors, especially over the last few years since I've been in Congress and as we've been working on ways to actually reform health care as opposed to what I think President Obama did, doctors will tell you the biggest area of you can call it waste, I would, the biggest area of work that they do that doesn't really relate to improving patients' health, but it's defensive medicine. They run tests that everybody knows they don't have to run, but they do it because they're afraid of frivolous lawsuits. In many cases, they've had to fight frivolous lawsuits, but it costs them a lot of money. So it's just something that every doctor will tell you they do. Do y'all consider, first of all, do y'all consider defensive medicine to be part of waste in the definition that we're discussing it today, Ms. King? Yes or no, if you could.
I don't know.
I mean,
I don't honestly know the answer.
Have you done any kind of research to know how much this does cost?
Defensive medicine, we have not done any direct work on that.
Mr. Roy or Perez?
I don't have a direct comment to that, but I want to say that we're putting people in jail that are committing fraud, not necessarily involved in.
Mr. Spiegel?
I don't know the answer to
that. I can't believe that especially Mr. Spiegel and Ms. King would say that you don't know the answer to what doctors will tell you is the biggest area of unnecessary spending, but something they have to do because they will get sued if they don't run that test. But they'll tell you probably a third of those tests are done not because they think it's in the best decision for care of the patient, but because they're afraid of getting getting frivolous lawsuits. And in fact, the president's bill does absolutely nothing to address that problem. And doctors will tell you that. People in the medical profession across the board will tell you that topic was completely ignored. The topic that doctors will tell you is probably the biggest cause of waste in health care. And so when we talk about adding another 20 million people onto the Medicaid rolls, at least, I would hope y'all would go back and look at just how much more we're going to waste in making these doctors run these tests, because in our bill, in our real reform bill after we've done repeal, we are including medical liability reform where you get dramatic savings in waste in health care. But I would ask if both Ms. King and Mr. Spiegel would go back and include defensive medicine and come back with us with some real costs. Will you get the committee that information on what you estimate are the costs that it adds to the system to have these defensive medicine practices that weren't addressed in the President's bill?
We can certainly look into it. I think it's a difficult question because what someone considers defensive medicine may be, an unnecessary test on someone's part.
But you can estimate the cost of that.
Well, there's a lot of variability in how physicians practice medicine.
As there is with anything that you give estimates on. appreciate that. Mr. Spiegel.
I mean, I would say the same thing Ms. King said. We could look into it, but the definitions of what falls into the category that you're trying to get a handle on vary depending upon to whom you're speaking.
Gentleman's time has expired. Mr. Griffin from Virginia is recognized for 5 minutes.
Mr. Spiegel, how many claims does CMS get a day? Do you know?
I don't.
And but it would be millions, would it not?
It would.
And do you have any idea what percentage of them you're able to review before payment is made?
Well, we do a substantial amount of review on virtually all of them before they get paid.
Okay. And I saw somewhere, I know that there was some testimony earlier that there was some indication that we didn't really know what the private sector's rate was, but I had seen somewhere or have information that their rate is about 1.5% loss to fraud. And I'm just wondering if you have seen that, A, and B, if you have studied what the private sector is doing to eliminate fraud, so you can see maybe if there are better ways for eliminating or preventing Medicare fraud.
Sure. I've seen some numbers for the private sector, and we did look into what it is about them that makes them different from us in the way they approach this. So in the private sector, they have a different approach to how they deal with approval of services that we don't do in Medicare, because we're designed as a program to get beneficiaries needed services and not to impose restrictions at the point of service. But private insurance can have prior authorization for a whole range of things that we don't. And so they can eliminate things that may have an impact on someone's need for services, or at least impose a barrier there that we don't operate that way.
Since there appears to be some intent to pay for all of this new health care by getting rid of this fraud, have you all considered going to a pre-approval process?
Well, we've had discussions. We've had discussions about that among ourselves, but right now it's not consistent with, I guess, our statutory authorities to be doing that.
And let me switch. I'm sorry.
If I might point out something else that's a key difference between the private sector and Medicare is that Medicare isn't any willing provider program. So the private sector has much more ability to restrict the providers who are coming into the program than Medicare does. Now, with some of the new authorities in the ACA, CMS is going to have more authority to take a closer look at providers and keep out providers who are not good actors.
Let me claim back my time. Let me ask, switching gears, just something that's kind of interesting. It's my understanding that the Medicare number, and I don't care whether it's Ms. King or Mr. Spiegel, but the Medicare number is the same as your Social Security number. Is that correct?
That is correct.
And then if somebody steals your identity, you can't just go out and change your Social Security number. Wouldn't it be a better policy to have each patient have a separate Medicare number, and then when somebody steals that number, the patient can get a new number just like you do with your credit card if you lose it or it's stolen by somebody?
Certainly there have been proposals made to that effect.
And we're doing a substantial amount of work right now to eliminate all the compromised numbers that we've identified for both providers and suppliers as well as beneficiaries.
But doesn't that have the impact on the one hand of making it very difficult for the patient? And then I guess I would ask, what is your opinion of that? You said that it had been talked about, but what do you think? Don't you think that would be a better policy, Ms. King?
I think it probably would be. There would be a question, I think, in our minds about what it would cost to effect that transition and how long that would take and what would be involved with that. Yes. Because you'd have to, every living beneficiary and then new beneficiaries as they come on the rolls.
And we agree
new
with
ones
that.
Would be a lot easier. That wouldn't probably
Yes,
cost you much
would.
at all. But anyway. All right. I yield back my time, Mr. Chairman.
Yields back his time. The young lady, Ms. Myrick, is recognized for 5 minutes.
Thank you, Mr. Chairman. Thanks to all of you for being here, and thank you, you two who do the investigative work, for what you are doing and the new way you're going about it. My question, I guess, is to Dr. Spiegel, Mr. Spiegel, I'm not real sure. On states, is there a requirement that states report fraud to you, to CMS, because I understand that maybe half the states don't even report data?
I don't know what the requirement is for.
Would you mind finding out and getting back?
Right,
Because I would like to know. And then the next question to that is relative to the states. Do they have their counties? Does it individually vary by state to state? But like in North Carolina, counties are responsible for reporting the fraud to the state. Is that something that happens across the country? You know, when you get right down to the local level where they have a better control on it maybe than the whole state does, is it more efficient?
I don't know about the efficiencies, and it would really depend on how each state is set up its operational structure for.
So each state's in control of how they report that?
I would think so.
But why do some states not report? Do you know?
I don't know the extent to which they don't. I mean, I know we have fraud investigation databases, and we collect information from states, and I think what I was trying to say before is I didn't know what the requirement was. I know we get reporting from states about the fraud cases that they uncover, and I'm sure they coordinate closely with the
Well, I would be curious to know. And then the second part of that, are there any minimal standards that states have to meet relative to, you know, the fraud, waste, fraud, abuse, whatever you want to call it, to receive their FMAP?
Well, again, I'm not a Medicaid expert, but there are requirements that states have to meet in order, you know, they'd have a proper state plan in place. They have certain administrative requirements they have to meet. They have to have a single state agency with authority. They have to have Medicaid fraud control units and things.
And then is there a follow-up on that to make sure that gets done? And I guess that goes back to my first question. Did the states all report? Anyway, I know if you don't know, if you can.
Well, I know there's follow-up on how the states organize themselves, and there's constant interaction between the folks in CMS who oversee Medicaid around that.
But all of you pretty much agree that there needs to be more of an effort on this relative to dollars that come from what you said before to the different people have asked you. And you've all responded that if there were more dollars into the program for what you're doing, you would have a better ability to do, particularly with the two in the middle, and what you do with the inspection work.
We have found that for every dollar we're spending, we're getting a substantial return on investment. 6.8%, I believe.
But yet there's, in the new health care bill, there's only, my understanding, $350 million in there for anti-fraud activities, which if that's divided up across all the agencies, you know, it's less than 1/10 of 1% of what we're spending on the health care bill. So it seems like it's a very small amount that's being dedicated to what really is getting at the crux of so much of the waste that everybody talks about is going to pay for all this. It doesn't seem to make sense. It seems like there should be more effort put into what you're doing from the standpoint of you're actually seeing results and you're getting to the bottom of the issue.
I mean, I guess we'd welcome the opportunity to have more resources to do more of the things that we've embarked on.
But I know Mr. Terry asked the question about actually if we could do this, what would it take type thing. So y'all are going to get back to him with that.
Yes.
I appreciate it. No more questions.
The gentleman, Mr. Murphy, Pennsylvania, is recognized for 5 minutes.
Thank you. I want to go over this list here, and I wonder if you can tell me if you have any idea where these fugitives are. A few of them. Carlos Benitez, do you know where he might be? Do we know what country he's in?
Sir, I may indeed know the general whereabouts of some of these individuals, but I do not.
Cuba?
Probably not, sir.
Are any of these folks in Cuba?
Probably not.
I understand that some of them actually may be.
Sir, I correct myself. There may be several of those that are in Cuba, yes.
Because my understanding maybe as many as 6, and the question is what the Cuba government is involved in here. If according to some reports that, quote, in a discussion with a high-level former intelligence official with the Cuban government who asked to remain unnamed, and this is from University of Miami report, he states there are indeed strong indications the Cuban government is directing some of these Medicare frauds as part of a desperate attempt to obtain hard currency. The source notes that the Cuban government is also assisting, while not directing, other instances of Medicare fraud, providing perpetrators with information with which to commit fraud. They go on to say, in the instance where the Cuban government is not directing or facilitating the fraud, it does provide Cuba as a place for fugitives to flee. This gives the Castro regime a convenient and carefree way to raise hard currency. Are we doing anything about that?
I have actually inquired before about what are the ties to Cuba, and nothing has been brought to my attention that would substantiate what you're saying. I'm more than happy to take a name and a number, or if you can get me in touch with that individual to follow up on that.
Okay, well, this was a report from the University.
The gentleman just yield briefly.
Not on my time. I only have a little bit of time. To just
I'd like to make a point of it.
The Cuban guy didn't yield yet because I really only have a couple minutes left.
Does the gentlelady request a personal privilege or a point of order?
You can do that and hold my time.
I just want to make sure.
Is this a request or point of order?
It's a request for a point of order.
Okay, sure.
I just want to make sure, and I know that you're not intending to ask Mr. Roy any information that would in any way undermine an ongoing investigation. I just wanted to clarify that. Because
Absolutely not.
He looked a little uncomfortable when you asked that question.
I'm just asking if...
Thank you very much.
Thank you. I appreciate that. This is a report from the University of Miami, and I'll be glad to let you read that. And it's just something I just want to bring attention, because it does bring to light there's also been concerns about other things happened by other countries where they may be doing this as part of an organized crime issue. Recognizing the ability to have false claims with Medicare actually may be easier, less risk, and lower penalties than it would be, for example, with cocaine trafficking, where you have long mandatory sentences. And so I'm wondering along these lines, if you're also looking to see, I mean, I appreciate the work you're doing. This is great. I'm glad you're pursuing this. The American people appreciate that. As Mr. Barton talked before, we're all in favor of this. I just want to make sure we're also looking at this as a mechanism to say, if you think we need more enforcement, do you need more funding, do you need more personnel, or do we need stiffer penalties, or all the above?
We need all of the above, sir.
Do you think the level of penalties is a factor in terms of people are willing to take the risk and consider jail time as the price of doing business?
Well, I certainly felt that way probably 5 to 10 years ago, but in the recent years I've seen across the board sentencing guidelines go up, and I've seen perpetrators of health care fraud go to federal prison for longer periods of time. If I had my way, they'd go there longer, but that's not the perfect world. But I see a movement toward a punishment fitting the crime, sir.
Thank you. Thank you. Anybody else comment on that? Mr. Perez or Mr. Spiegel? What additional tools, then, do you think that Congress can give all of you with regard to helping investigate Medicaid and Medicare fraud and abuse cases? Is there any other tools you want from us on the other?
First and foremost, the funding aspect of it. The funding has to be continuous. It has to be long-term to ensure that I can keep bodies on the ground. It can't be a one-shot in the arm type of a situation. Our organization is human resource driven, and the more agents I have in the field and the more support staff I have, the better job I'm going to be able to do.
I appreciate that. Anybody else can comment on anything? Yes, Mr. Price.
Just from an investigative standpoint, and I'd mentioned this earlier, I apologize if I'm repeating myself, at least to you, but we certainly would like to have real-time data access so that we can see the claims as they're hitting them. We currently don't have that, and there's another system that's out there that we would also like access to that actually gives us the profile of the providers that are in, so that we know once they're in all of the makeup of that particular provider, and then we can initiate investigation.
Do you have that profile access now, or is that something you're asking for in addition?
We do not have it now.
So to be able to get that profile information on the providers and the real-time data, so you could, I guess, more or less profile as people are submitting claims. If there's things that appear to not match standard billing procedures with durable medical equipment or services, that would show up, and you could hit on that right away. Would that help you?
I think that certainly would help us, yes.
Mr. Spiegel, do you have a comment on that?
Sure. And what I would say is the President's budget's laid out a number of things that we would want to do in 2012. And for now,
we need to have a little bit of time to gauge the impact of all the things that we've started doing in the last year, to refocus our efforts on the front end and to take prompt action on the folks who needed to have action taken against them.
Thank you. I think it would aid the chairman if any of you had any other details of how that would work out to let the committee know. Thank you so much.
Gentleman's time has expired. The gentleman, Mr. Gardner from Colorado, is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today. Appreciate your work on something that obviously everybody is concerned about. In Colorado, we were able to do a couple of things to detect fraud, to fight back against those who had abused the system. We passed legislation that would freeze para benefits, that's the public pension fund. If it was a public employee that was involved, it allowed the para board to freeze those assets. We also tried to pass legislation that said if you were a contractor, a provider that had been convicted of fraud elsewhere, that after a certain point you were barred from dealing with the state of Colorado. And so I want to get into that a little bit for a couple questions. And Mr. Spiegel, wanted to follow up on one of your responses to Mr. Griffith. I believe Medicare receives about 4.5 million claims a day, and you substantially review every single one of those claims?
In some way, we verify that the person who sends in the bill, for example, is enrolled in Medicare, and that the person who received the services is an eligible beneficiary. I mean, there are automated claims edits that are in place that look at that.
How many would you say you substantially review, that you're actually able to really look at? Because that's all automated. I mean, what percentage are you able to actually look at to detect?
If what you're talking about is, do we take an opportunity to collect medical records and make a judgment about the clinical conditions that were present and things like that, I don't know the exact percent. I could get back to you with that.
That'd be great if you would get back to me on that. Thank you. And then, Mr. Spiegel, we've heard that in terms of both durable medical equipment and home health, both are highly susceptible to fraud. What other areas lose a substantial amount to fraud?
Well, in our recent screening rule, the ones that we put in the high level risk category were newly enrolling DMEPOS suppliers and newly enrolling home health agencies, and those individuals or entities that hit some of the triggers that we put in the rule. There are examples of other provider and supplier types that we've uncovered and that the Inspector General's work has identified that maybe not as a class, but as individuals have had some problems.
And I see when you, in your testimony where you talk about delivery system reform, you talk about inflated prices that could lead to increased fraud, but you've only made reforms in, I believe it was 9 areas. Why did you just add those reforms in 9 areas? If you're overpaying somebody, shouldn't we reform them all?
The 9 areas were in statute.
So if they're being overpaid and it's causing fraud, do you have an ability to add to those 9 areas?
I don't know the answer to that. Do we know? Over time, we have an opportunity to add to that based on what we learned from our work.
Okay, and over the President's budget 2012 said that we're going to recover about $32 billion in fraud. Is that how much fraud there is? What percentage of fraud total are we recovering?
Well, as I mentioned before, we don't know the exact number because the estimates that we've all seen contain things that are in addition to fraud. They contain improper payments, they contain administrative errors, they contain both public and private sector estimates. Until we can get to one number that identifies fraud, which is in a sense a legal determination,
when do you,
we're not going to be able to answer
at what
that.
point is a provider barred from doing business with a Medicare Medicaid provider?
Well, it would depend on the circumstances.
After one time they've been found fraudulent?
Well, it would depend on, we don't determine fraud at CMS. That's a law enforcement decision. And if somebody's been convicted of fraud, the Inspector General has the opportunity to exclude them from the program for a period of time.
So if somebody's convicted of fraud, are they automatically barred?
Sir, yes, they are.
Okay. And then are states using that then to bar them from their Medicaid programs?
We're working on that issue right now. I'm not sure how in-depth the state goes with respect to who they exclude from their program.
We have provisions in our recently published rule to implement that so that when someone's excluded from Medicare, states will be doing the same thing, as well as states excluding from Medicaid entities or individuals that have been excluded by other state Medicaid programs.
What happens to the money that you're recovering from fraud? Does that go back into fraud-fighting efforts?
By law, money that we recover goes right back into the Medicare Trust Fund.
Yes. So it does not go into additional fraud prevention?
No, sir.
Okay. Yield back my time.
I thank the gentleman, and I thank the first panel for their indulgence and forbearance here. Just let me finish. I'll be glad to recognize you. There was a question Mrs. Spiegelow was asked you, and you did not know the answer concerning the claims per day. I thought I'd put in the record that the Health and Human Services Bill Core testified in front of the Senate Finance Committee in October 2009 that CMS gets 4.4 million claims a day, and with the requirement to pay within 14 to 30 days, and they are only able to review 3% of the prepayment. And the gentlelady from...
I just ask unanimous consent to follow up on one question.
Sure, go ahead.
Mr. Perez, someone asked you if you needed more powers, and you said you'd like to be able to access claims data directly when you're on these investigations. Do you need, is this a matter of more authority to be given to you by Congress, or is it just the procedures that your office is using?
I believe it may be an internal issue with the department working with CMS and allowing OIG then to have direct access to that data.
Okay. If you need more powers, let us know, because it would seem to us to be good information for you to be able to access. Thank you.
Thank you, gentlelady. We have another member who's joined us. The gentleman from California, Ms. Bilbrey, is recognized for 5 minutes.
Thank you. Mr. Perez, we were talking about the ability to impound. IRS has been given that power to impound. So why wouldn't we, if we're as serious about making sure that taxpayer funds aren't going out inappropriately, wouldn't we at least give you the authority that we give to the people who are to make sure that revenue comes into the federal government appropriately?
I'll take that. If I could, sir,
Go ahead.
I'm more than willing and happy to look at that particular issue in terms of the ability to impound. We do seize bank accounts. It's more the matter of physical assets, but I am more than willing to take any additional resources that come my way.
Okay, I'm just concerned because you see the disconnect that we take income of the revenue very seriously, but traditionally we haven't put as much weight on reviewing and oversight and recapturing of assets coming back. And Ms. King, I appreciate your kind words about the wrongful payment bill. I was one of the authors of that bill, one of the few bipartisan bills that got passed last year. But I don't think that weight has been traditionally applied, and I'd like to make sure that we do it. Speaking of the IRS, the fact is a lot of these people are engaged in fraud and abuse. I have to believe, as a former tax consultant, that once they get in the habit of filling out applications for revenue from Medicare and Medicaid inappropriately, I have to believe there's got to be more opportunity in there to engage the IRS to be able to be involved with this. Remember, it wasn't the FBI that got Al Capone, right?
Sir, you're correct. We work joint cases with IRS CID all the time just for that purpose.
Okay. Mr. Spiegel, I have a concern with something you said. I know that this is waste, fraud, and abuse in here, but you appear to take wrongful payments as being sort of separate and apart from waste, fraud, and abuse.
Well, from fraud.
Okay, from fraud. Okay, and that's why I want to clarify, because you will admit the impact to the taxpayer and to the federal family is financially the same between wrongful payment and fraud.
We're against all of it. We're against improper payments and fraud and waste and abuse.
Okay. So the fact is that we need to fast track those items and get it there. One of the items that have been brought up was the fact of the use of false documentation, identity theft. Now, we usually talk about identity theft in different fields, and we've gone around with the use of identity fraud to falsify employment opportunities, illegal presence in the country, and everything else. But the identity fraud issue that we've seen here with your enforcement of the ability of somebody to get a driver's license, get a document, and use it as a fraud, that has been documented in your enforcement as a vehicle that organized crime or these bad guys are using in implementing their fraud to the healthcare system.
Certainly, and in Miami, I know that in those instances where we are able to prove that beyond reasonable doubt, we certainly are including those in indictment.
Has Florida implemented the Real ID bill yet? You know?
That I do not know, sir.
Okay. Mr. Chairman, I just think that we need to point out that that's one bill that we passed how long ago, which was a basically #1 request of the 9/11 Commission, but we still have states that are looking at dragging their feet about using biometrics, and biometrics is one way we could catch these guys. You have biometrics to a driver's license under one name, you do the other. Anybody who watches NCIS knows that we've got that computer technology. We've had it in California since '78. That they will get busted coming in, one guy coming in as Smith, another guy coming in as Martinez, and we cross-reference those biometrics. So I just want to point out that I think that the federal bureaucracy needs to be sensitive that the states are the people that provide the IDs in lieu of a federal ID. That Real ID is a way we can secure the system without having to have a federal ID and make sure, there's one reason why we've got to be serious as federal agents to push that the states have to do their part down the line. And maybe, Mr. Chairman, our committee can recommend to Homeland Security that before we send money to states for Homeland Security projects, that we require that the first priority, that if states haven't implemented Real ID and secured this identification issue, that should be the first project used with federal funds on Homeland Security. And with that, I yield back, unless anybody has a comment on that. Thank you very much. Appreciate it.
All right. Thank the gentleman. That could be your piece of legislation. So I want to thank the first panel again. We'll move to our second panel and ask the Honorable R. Alex Acosta to come up, and Mr. Craig H. Smith and Ms. Sarah Rosenbaum. And I invite all my members to stay for the second panel.
Thank you.
Thank you. The Honorable R. Alex Costa is a native of Miami and the current Dean of the College of Law at Florida International University. He received his law degree from Harvard. He served as a law clerk to Justice Samuel Alito, then a judge on the U.S. Court of Appeals for the Third Circuit. He's been the longest-serving U.S. attorney in South Florida since 1970, sitting as a Senate-confirmed United States attorney for the Southern District of Florida. Our second panel is Craig Smith, is a partner of Hogan and Lowell's. He rejoined the firm in 2008 after serving as a general counsel for the Florida Agency for Healthcare Administration, while serving as a chief legal officer of one of the nation's largest Medicaid programs. He coordinates frequently with the federal officials at the Center for Medicare and Medicaid Services and the Department of Justice. And our third panelist is Sarah Rosenbaum, who received her her JD from Boston University Law School, has played a major role in the design of national health policy in areas such as Medicare and Medicaid, private health insurance and employee health benefits, access to health care for medically underserved persons, maternal and child health, civil rights and health care and public health. She also worked for the White House Domestic Policy Council. So I thank all three of you, and we welcome the Honorable Mr. Costa for your opening statement of 5 minutes. Thank you for staying with us.
Thank you, Mr. Chairman, Ranking Member DeGette, and distinguished members of the committee. I appreciate the opportunity to appear before you to discuss waste, fraud, and abuse in Medicare and Medicaid. As the Chairman mentioned,
let me just swear you in, if you would. If you don't mind, please stand and raise your right hand. You swear to tell the whole truth and nothing but the truth, so help you God.
Do.
Yep, thank you. Sorry. Go ahead.
Yeah, that's an important issue. As the Chairman mentioned, I served as the United States Attorney for the Southern District of Florida from 2005 to June 2009. Early in my term, I made prosecution of healthcare fraud a top priority in my district. I organized in 2006 the South Florida Healthcare Fraud Initiative because I became convinced that waste, fraud, and abuse threatened the key viability of the Medicare system, and as a result, we became home to the first Medicare fraud strike force in the nation. The results were spectacular, but they were also very sad. By 2008, we accounted for 32% of the nation's healthcare fraud prosecutions. From fiscal year 2006 through May 2009, my district charged more than 700 individuals responsible for more than $2 billion in fraud. That is actual fraud charged in criminal indictments. I heard this morning that figure now stands at $3.5 billion. Put differently, those $2 billion, which is $2 billion, are sometimes hard for the common folks to imagine, like me. So I put it in per beneficiary terms. That's $1,900+ per beneficiary in South Florida. Numbers alone, though, don't tell the story. I wish, and I was very happy to hear that some members are going to do ride-alongs, because I wish more members could visit the strike forces. If I was U.S. Attorney and if you visited South Florida, I would take you to our facility. There we have a wheelchair that we've shown to other interested individuals. The wheelchair was built again and again and again. The same wheelchair, not used by patients. We call it the $1 million wheelchair because it was built that many times. We have boxes after boxes of evidence. We have pictures of a pharmacy, and that pharmacy was billing thousands, perhaps millions of dollars in expensive brand name inhalation drugs. In fact, the pharmacy was a broom closet, and there was nothing there. That level of fraud should absolutely disgust each and every one of us. We enjoy one of the world's best healthcare systems, but we often hear of the skyrocketing cost of healthcare, and we worry that one day we will not be able to afford quality care. Reducing fraud, as you already mentioned, is, in common parlance, a no-brainer. It should be a bipartisan effort. Now, let me say I'm proud of the work we did in South Florida prosecuting fraud, but fraud is not the solution. We need to prevent fraud from happening in the first place. Prosecutions have limited deterrence. The sentences, while increasing, are not sufficient to fully deter fraud. Prosecutions are resource-intensive. Prosecutions rarely recover taxpayer dollars wrongfully paid out to fraudsters. The fraudsters, by the most part, spend the money or send the money overseas. Prevention is the preferred approach. Think of this as perhaps analogize fraud to a busy intersection. How do you prevent accidents at a busy intersection? Do you post a police officer at that intersection and ticket cars after they commit accidents? Or do you put a red light at that intersection and prevent accidents in the first place? In the same way, we need to prevent fraud in the first place. Prosecutions are not the solution. Now, effective prevention requires a lot more than front-end screening. Effective prevention requires continuous and proactive efforts to identify and stop fraud as it happens. The gentleman from Virginia, Mr. Griffith, mentioned the issue of unique IDs. Well, Mr. Chairman, Ranking Member DeGette, I assume both of you have credit cards. Imagine if you lose that credit card and you call American Express and you say, I just lost my card. And they say, thank you very much. We can't issue a new card with a new number. When you get fraudulent charges, let us know and continue to let us know in the future because we cannot cancel your card. How long would American Express stay in business? But that is the system that Medicare uses. Your Medicare number is your Social Security number, a number that is easily found, a number that can then be used to bill in your name, and that number cannot be changed. Effective predictive modeling is another tool that can assist with fraud prevention. An example of how effective this can be comes out of South Florida. South Florida, in 1 year, was responsible for $92 million in budesonide billings. This is an expensive inhalation drug. And inhalation drugs were a large problem in South Florida. Well, the Office of Inspector General did a study to look at these billings. 74% of the beneficiaries for this drug submitted claims that exceeded the 90-day coverage maximum. any private insurance company would say, if you exceed a coverage maximum, we're not going to pay. 62% of those that allegedly submitted claims for these drugs, in fact, hadn't seen a prescribing physician in 3 years. 10 doctors in South Florida were responsible for more prescriptions for this drug than all the doctors in Chicago combined. Chicago is the next highest billing city. These are the kinds of issues that predictive modeling should catch. These are the kinds of issues that should be caught pre-payment. Experience shows that prepayment prevention, computer models that identify aberrant billing patterns, that stop payment when you see spikes like this, are the preferable approach. Post-payment pay and chase does not work. Now, I've heard this morning that CMS is moving away from pay and chase, and I think that is a wonderful idea. It is an important issue because we need to catch this before it happens. After the fact, my former colleagues and good friends at OIG can prosecute with DOJ, but that is not going to solve the problem. Thank you.
Thank you, gentlemen. Mr. Smith, you're recognized for 5 minutes.
Thank you, Chairman Stearns, Ranking Member DeGette, and distinguished members of the committee. Thank you for inviting me to testify today. I do want to say at the outset that I'm here in my personal capacity and that my views are not necessarily the views of my law firm, Hogan Lovells, or any of the firm's clients. I was asked to appear today to share with you my views of ways we can detect and prevent Medicare and Medicaid fraud and abuse based principally on my time serving as General Counsel of Florida's Medicaid program, which, as you've heard, operates one of the nation's largest Medicaid programs in this country. Now, we've certainly heard this morning about the serious problems that have plagued the Medicare and Medicaid programs in terms of fraud, waste, and abuse. The real concern is that the expenditures under both programs, as shown by the chart that's on the screen before us today, are set to significantly increase over the next 10 years. And this means that there's an even greater number of bad actors who will look for ways to defraud these programs. In the past 10 to 12 years, Florida officials realized that the rapidly rising costs of the Medicaid program were threatening the state's long-term financial health, and they began focusing on prepayment fraud and abuse prevention. That's going to be a current theme you're going to hear with me, as you heard from Mr. Acosta and others today. Florida officials also began administering the Medicaid program more like a private health insurer would do. The Medicare program, in contrast, has, for the most part, continued along the pay and chase approach, as we have heard. And that made Medicare an especially easier target for fraudsters, especially in South Florida, as compared to Medicaid. The recent sting operation involving 700 federal and state law enforcement officials across the country to apprehend 111 suspected health care fraud criminals was impressive, but it shows that at a rate of about 7 law enforcement officials to every 1 person arrested, the post-payment prosecution method is inefficient and highly expensive. In the written remarks I submitted to the subcommittee, I offered several recommendations for preventing fraud and abuse in these programs. For purposes of my testimony today, I'd like to highlight 3 of those that have been very effective in Florida's Medicaid program. Number 1, the first recommendation is that the programs need to better control the provider enrollment process and provider network process. You heard Ms. King testify this morning from the GAO that the Medicare program is an any willing provider program. This is a problem because bad actors should not be able to gain access to the program. One of the most egregious stories involves a Miami man who served 14 years in prison for murder and then recently purchased a medical supply business for $18,000 and proceeded to bill the Medicare program for over $500,000 in false claims. Now, he was eventually arrested, but that was only after he was charged with murdering another person and dismembering that person. This is the type of person we should not have in any of these programs, and a better provider and screening and enrollment process would catch that. The other thing I want to highlight about the provider network process, going back to this any willing provider approach in Medicare, is despite some misconceptions, there is no constitutional right for anyone to be a Medicare or Medicaid provider. There are entitlements for the beneficiaries, but there's not a constitutional right to be a provider in these programs. Florida understands that in its Medicaid program and has added without cause termination provisions in its Medicaid provider agreements. These allow the program to very quickly get bad actors out of the program or people we don't need in the program, whereas the Medicare program has really struggled expelling bad actors. The second recommendation I have for the subcommittee is that the programs should consider shifting away from fee-for-service reimbursement methodologies that are ripe and very susceptible for fraud and abuse and move toward other payment systems, including managed care. Risk-based managed care companies have a financial incentive to detect and prevent provider fraud and abuse in these programs. They can be a helpful partner to the government in stopping provider and fraud and abuse and saving taxpayer dollars. My third recommendation is that the programs, as Mr. Acosta said, should use predictive modeling and other analytical technologies. Prepayment predictive modeling has been used to analyze healthcare claims for many years, but in the past its effectiveness has been hampered by the inability to limit false positives and produce focused, actionable results. Well, those technologies have significantly improved. And so today, just as the credit card industry is able to send its cardholders an instant text message or alert if there's a suspected fraud transaction, the Medicare and Medicaid program ought to be able to do that up front. And as Agent Perez testified this morning, it would be great if they could do that in real time as the claims are coming in. In 2008, Medicare paid home health agencies in South Florida over $550 million just to treat patients with diabetes, and that's more than was paid to every other locale in the entire country combined. Predictive modeling can stop that. So we've heard that the fraud, waste, and abuse program is very real, and I applaud the committee for having this hearing today. If we focus on prepayment for prevention, that is the way to best protect taxpayer dollars, and I welcome any questions you might have. Thank you.
Thank you. Ms. Rosenbaum, you're welcome for 5 minutes, your opening statement.
Thank you, Mr. Chairman, Ranking Member DeGette, committee members. You have heard so much information this morning that what I would like to focus my comments on have to do with a question that arose during the question and answer period that I think merits a closer look, which is the extent to which fraud and abuse are issues in private insurance, not only in private insurance, but actually fraudulent and abusive activities by private insurers. One of the great things, in my view, about the Medicare and Medicaid programs is that they are public programs, and so we are able to know a lot, as evidenced by the testimony this morning, about the extent to which fraud, waste, and abuse may be happening in the programs. They are extensively studied. There are many, many reports. You have made many incredibly important investments in curbing fraud, waste, and abuse in Medicare and Medicaid, and those investments have begun to yield real benefits. We know very little, actually, about fraud, waste, and abuse in private insurance. We do know that since 1995, according to at least some studies, 90% of health insurers have begun to institute more significant anti-fraud efforts. Clearly, they've concluded that they are experiencing some of the very same problems in their payment systems that Medicare and Medicaid are experiencing in their payment systems. I would note that one factor about the Medicare and Medicaid programs that may make them slightly more susceptible to fraud and waste, and something that I think would be very hard to remedy even were the entire Medicare and Medicaid system changed, is the nature of the beneficiaries. A lot of studies show that fraud generally is more concentrated in communities and among populations who are extremely poor, extremely disadvantaged, and much more vulnerable to fraud. Whether they were given public insurance or a voucher to buy private insurance in communities with high concentrations of poor and vulnerable populations, this is an issue, and the investment of federal resources and state resources in protecting them against fraud is enormous. I think there's something else that's worth mentioning, and that is when we see fraudulent behavior by the insurance industry itself. And there are actually three kinds of fraud behaviors that I think are worth thinking about as you contemplate further efforts to try and reduce and prevent fraud. The first, of course, is Medicare Advantage marketing abuses. They are extensively documented. A simple Google search of Medicare Advantage marketing abuses shows thousands of reports. One of the most interesting is a study in rural Georgia. A group of public health students, near and dear to my heart since I'm a professor of public health, took on as a summer project an effort to try and uncover marketing abuses in rural Georgia by Medicare Advantage salesmen going door to door. I would note that one of the best websites on the problem and what can be done about it is found in the Texas Department of Insurance, so this is something that state insurance departments are aware of. A second kind of abuse is an abuse in which a health insurer negotiates deep provider discounts, fails to disclose those discounts among its network providers to enrollees, who then, instead of paying what they think is a 20% coinsurance rate, are paying coinsurance rates that are, in some cases, actually even more than the fee that was paid to the provider. And a third type of abuse, one that was disclosed by Attorney General Cuomo, is the abuse that we saw in the Ingenix cases, in which out-of-network provider payment standards are manipulated, reduced, and enrollees who thought they had out-of-network coverage are in fact gouged and made to pay very high balance bills. Now, these issues, I think, are important to focus on as we move into a time when tax subsidies are flowing into the purchase of private insurance products in health insurance exchanges and other locations. And so my strongest recommendation to the committee would be to consider further steps to empower investigation of insurer fraudulent and abusive behavior. Thank you.
Thank you. And now we'll just, I'll start with questions. I just note, Mrs. Rosenbaum, that you had indicated that you're a strong supporter of the public sector, but the public sector, Mr. Spiegel, could not tell us at all how much fraud is in the Medicare system, but I can assure you that in the private sector, they'd go out of business if they didn't know that. If they couldn't answer that question on a continual basis, they'd go out of business. Mr. Smith has outlined 3 ways he thinks he could prevent waste, fraud, and abuse, and of course the predictive modeling using computer was one that you mentioned, Mr. Acosta, too. Do you agree, or would you add to the 3 that Mr. Smith mentioned? I thought were pretty incisive. Are any other ones you would suggest?
I would agree with that, and I also would like to support a prior comment made about the importance of data access. One of the ways that we were able to bring as many cases as we did in South Florida, and is we employed a nurse practitioner that had access to not real-time data because we couldn't obtain that, but fairly recent data to look for billing spikes, and we did that ourselves rather than have through the HHS OIG agents rather than defer to CMS. That kind of integrated data is very important, and I'd like to support Mr. Perez's request.
Mr. Acosta, Mr. Smith, do you think we should have Medicare issue something besides a Social Security number so that they could actually, when a person called and said, listen, there's fraud in my billing here, instead of saying, well, just keep alerting us, they've got your Social Security number, do you think we should change that? Because that was not one that either one of you suggested, and that's been mentioned.
Well, let me apologize because I thought I had referenced that. Okay. I think it is absolutely critical. As U.S. Attorney, we would get calls on a weekly basis from individuals saying, we have 2 legs, yet Medicare is paying for a prosthetic leg. Medicare says they can do nothing about it.
In a 60-minute expose, there's a woman there who said for 6 years she called for artificial limbs, artificial legs, 6 years, and Medicare did nothing.
Mr. Chairman, how long would American Express be in business if
That's
when you call and say, I lost my card, they say, we can't help you?
Yeah. Are either one of you concerned that here we're expanding the Medicaid program by 20 million people under Obamacare, and federal spending on Medicare and Medicaid will rise from $900 billion in 2010 to almost $2 trillion in 2019? Are you concerned that, unless we implement these things, that obviously we're going to have more fraud?
From my perspective, I think it's critical that Medicare and Medicaid spend money to modernize their system. That involves unique IDs, not the Social Security number. That involves predictive modeling. Again, credit cards, if your spending patterns deviate at all, call you up. Why can Medicare not do the same thing?
Are you familiar with what the Medicare prevention fraud in the bill does? Are either one of you, Mr. Smith and Mr. Acosta, do you think they would help pay for the cost of this Medicare expansion and Medicaid expansion just based upon what you see in the bill, or do you know what's in the bill?
Well,
no, go.
I certainly am aware of some of the provisions in the bill. I think one of the big concerns is we heard testimony today from the OIG saying that the current problem, the current Medicare and Medicaid fraud problem with the current population of beneficiaries we have exceeds, in his estimate, $7 billion. So even if you took the CBO's suggestions that the additional funding in the federal health reform legislation could help save $6 or $7 billion, that's barely enough to get close to the estimates of what the OIG says is the problem today.
Excellent point. Excellent point. Mr. Costa, anything you
And yes, I would add to that most of the, I assume you're referring to the ACA, most of the ACA focuses on screening measures, licensure checks, background checks, site visits, which are important. But it's not enough. You need to actually review claims as they come in using predictive modeling. You need to have prepayment screening of claims.
Yeah.
And Chairman, I would echo that and say that that's why I really think it's important as part of the Small Business Jobs Act. That's where the predictive modeling legislation was added. That's not part of the original federal health reform legislation. And so I think that predictive modeling and analytical technologies.
It's hard to believe. So the predictive modeling using computers is not part of the prevention program in Obamacare right now. Is that the way you understand it?
Well, I think that the federal health reform legislation does ask and does provide for additional technologies to be used, but the predictive modeling piece and the key piece for prepayment
is not there.
Analytical claims.
I'm just going to close by asking you quickly. In your opinion, do you think organized crime involvement in Medicare and Medicaid has been, pretty prevalent in South Florida? Have you seen a lot of organized crime figures engaged in Medicare fraud? One of you?
I certainly haven't. If I could just clarify a small point, the Small Business Jobs Act of 2010 did have authorization for predictive modeling. HHS is looking at this, but the authorization was put in a separate provision. With respect to organized crime, I think it is a clear method by which organized crime makes money. It is highly profitable. We're talking not millions, but billions of dollars. $2 billion in actual charged criminal indictments. That's not all of it that's on the street. That's simply what we proved in court in South Florida alone. One of the frustrations is when you take down an operation, when you do these national stings, you get the nominee owners, the individuals that are being paid a little bit of money so their name can be used, but they're not really the brains behind the operation. And so you need to go up the chain just like you do in organized crime.
All right, my time has expired. The gentlelady from Colorado.
Thank you so much, Mr. Chairman. So, Mr. Acosta, what you're saying is in fact, Congress did pass the predictive modeling, the prepayment information. It was just not in the same bill as the Affordable Care Act, correct?
Correct. If memory serves, I believe Senator, I don't know on the House side, Senate side, Senator Lemieux.
So it's in the law now. We can do that, right?
HHS has the authorization if they choose to use it.
The authorization. Now, both of you, I want to thank all three of you for your testimony, because I thought it all gave good different perspectives on how we can target waste, fraud, and abuse. And as we said with the last panel, we're all interested in rooting out waste, fraud, and abuse in every part of the system. One of the new tools that we talked about that is in the Affordable Care Act and that CMS and HHS are using is this preventative approach, so that we're moving away from the pay and chase model to the model that emphasizes keeping criminals out of the system to begin with. And I would assume, Mr. Costa, you would agree with that approach, correct?
I entirely agree that the pay and chase is a bad approach and that
Thank
we need
you.
to move.
Mr. Smith, would you agree with that?
Absolutely agree that's not a good approach.
You don't think that the preventative approach is a good approach, or you don't think the pay and chase is a good approach?
Pay and chase is a terrible.
It's a bad approach.
Yes.
And what about you, Ms. Rosenbaum?
I agree that prevention is the best approach.
Okay. Now, Mr. Smith, you testified. This was really quite shocking to me. You said that there's this any willing provider rule, which would allow even people with murder convictions to become a provider. Here's my question. Is that under statute, or is that just under practice?
Well, Ms. King testified this morning referring to the any willing provider rule. Basically, CMS's approach historically has been to let providers in unless they clearly had an issue in the screening process that CMS caught, and they weren't very good historically at catching those problems.
Okay. So do you think that there are some criteria that we could pass that would be absolute barriers, like, for example, a felony conviction, where you would say, because I know they use their discretion, so they could reject somebody for having a felony description. Are you saying that it would be a good idea for us to pass a bright line of certain criteria that they just couldn't consider somebody if they met those criteria?
Certainly, and there are certain criteria in statute that are bright lines, but I would say that it goes beyond just felony convictions. It also goes to operating your provider network like an insurance company would, which is if we have too many home health agencies in Miami-Dade, regardless of whether we think a particular provider is fraudulent, we shouldn't let more agencies in the.
Yeah, I mean, I agree with that, but that's not a bright line. That's sort of a discretionary criteria, and that's what I'm asking you. So if any of you actually think that there are additional bright line criteria we should put in statute, we'd appreciate it if you'd supplement your answers and provide that to us, because I agree with you. Those kinds of outrageous things should not be happening, and sometimes I do think they slip through the cracks. Now, Mr. Acosta, you testified that one thing that would be really helpful would be using these unique IDs, not using Social Securities, correct?
Correct.
Mr. Smith, do you agree with that would be a good way to improve the system and to decrease fraud?
Yes.
And Ms. Rosenbaum, do you agree with that too?
I do.
I think that's a really great idea, and I appreciate you bringing that up. I guess that's all the questions I have. I'll get back.
Thank you, gentlelady. Mr. Murphy from Pennsylvania is recognized for 5 minutes.
Thank you, and thank you to the panel. This is very enlightening. Mr. Costa, could you were talking about, a couple of you and Mr. Smith, talking about issues involved with prevention versus chasing. Do we have any estimate of the costs involved with bringing a Medicare or Medicaid fraud case to justice, from bringing charges to jail time?
The costs, well, I can tell you that in my office I received a line item of about $1 million. I supplemented with about $2.5 million of my own discretionary spending, and so I spent about $3.5 million per year to prosecute cases. Now, that does not include the costs of the agents from HHS, OIG, and FBI.
Do you have any kind of ratio then of with regard, and to make decisions with regard to whether or not to prosecute a case if it's less than $1 million or so, and it's going to cost you $3.5 million?
We have cutoffs all the time. We don't like to discuss them publicly, but obviously you have more cases than you can imaginably prosecute, and so you go after the larger cases, and that is a problem. And every now and then we prosecuted some smaller fraudsters because you don't want to send the message that if you stay below a certain number, you get away with it.
What would the cost of prevention be?
The cost of prevention at the end of the day, I think, are much lower and much more effective. Computer programs that screen, for example, inhalation drugs in South Florida. Budesonide that I mentioned is just one, but there are a number of other inhalation drugs. In 1 year, Miami-Dade County received $93 million in billings. The next highest billing city was Cook County with $2.7 million. That is a red flag if I've ever heard one. That is the kind of issue that should be caught by a computer program. And if you can prevent those $93 million and reduce it to the cost of Chicago of $2.7 million, that's $90 million that you're preventing right there.
Thank you. And Mr. Smith, on any willing provider issue, how do you recommend we define providers? Obviously, we don't want to stop people who want to start a business, who are legitimate about it. But should it involve such things as the ranking member was talking about something along the lines of a criminal background check requirement, or would these be people who would be of a higher level of screening for their first year or two? Would they be licensed would they be specifically licensed on on some other level to begin with, probationary? Do you have any recommendations for that?
There already exists in law provider screening requirements that would look at convictions, different things in the person's past. And CMS did just recently come out with a final rule regarding provider screening enrollment, and what they've done is try to tier the risk areas. So a provider seeking or a person seeking to open up a new Medicare certified durable medical equipment company, a home health agency, or perhaps an infusion clinic would be tiered in a higher risk category and perhaps be screened closer than someone hoping to open up a new hospital, and I think that's a wise idea.
Do you think, with regard to these issues, and your familiarity with Florida, I don't know if you heard my questions before regarding the question of the Cuban government's role in this, would we have picked up on this? Is there any thought that we might pick up when another country is involved, perhaps in organized crime? With this?
I think from a Medicaid perspective, part of it goes to not only making sure you screen for certain bad actions in their past, but also making sure you collect enough data to get the people on the applications so that you know what the links are. And one of the things that's beneficial about the predictive modeling is not just the claims analysis, but also it has the capability of doing what I call social network analytics. So you can basically see which people who have had an experience with a fraudulent enterprise have links to other people that you might not be aware of, might not have their names in any applications, but they're operating in clusters, and they sort of swarm around like bees with patients and defraud the program. That type of technology has great opportunities for us to save money.
Mr. Costa?
Congressman Murphy, thank you. If I could, you asked earlier, you referenced the list of OIG's most wanted, and based on public information, my understanding is that a majority of these individuals are in fact in Cuba. One of the issues that we had early on was that defendants were being granted bond by federal judges on the theory that because they were Cuban nationals, they could not return to the island of Cuba. And in fact, they were then jumping bond, and we had a law enforcement problem. Since then, federal judges have actually stopped using the fact that someone may not flee to Cuba as a reason to grant bond because of reduced risk of flight, because in fact the risk of flight to Cuba is high, because Cuba welcomes the hard currency that they receive from these individuals.
Thank you very much. Thank you, Mr. Chairman.
Gentleman from Virginia is recognized. Mr. Griffin, for 5 minutes.
Thank you, Mr. Chairman. I do think that's very interesting. So even if the Cuban government's not involved, they still welcome these folks in because they're bringing cash with them.
They certainly welcome them in. There's some evidence that shows that there is governmental involvement as well, but that is based on University of Miami reports.
Interesting. Professor Rosenbaum, I'm just trying to check out and do some things on background, and I would just ask you some questions, if I might. I see that you've listed some government contracts on your truth and testimony form, and I'm just wondering if you could tell me what those contracts involve.
Sure. I am a law professor at George Washington University, and I'm a chair of a Department of Health Policy in the Medical Center. And I am the principal investigator on a contract that provides analytical support to what is now, I guess, the center as opposed to OSIO, it's CSIO, to review and summarize the comments for the requests for comments and the notices of proposed rulemaking related to health insurance exchanges.
Okay. And so they don't have somebody in-house that's doing that?
Oh, I'm sure they must review as well, but we do policy support work for the department and have under federal contracts for administration since 1991.
Yes, ma'am. And is there anything else you're working on with HHS or CMS in regard to the Affordable Care Act and the regulations?
I have no other contracts in which I am the investigator, no.
All right. I appreciate that. Thank you, ma'am. I yield back my time.
Gentleman yields back his time. I think we're all through. I'm getting ready to close. I did have one follow-up with Mr. Smith. I think you talked about, or maybe it was Mr. Costa, about the using a data access process to cut fraud. I wasn't quite sure because Inspector General and GAO can go in and look at these statistics to get. But who were you talking about when you talked about data access?
One of the issues that we had early on in South Florida for the healthcare fraud initiative that later became the strike force, we set up a separate location where we co-located the agents and the prosecutors to focus on this. At the time, I had requested that that everyone have access to the billing data so they could look for aberrant billing patterns. We were finally able to obtain access to some data, and that was restricted in appropriate ways at the time.
So you want law enforcement agents and the
Absolutely.
prosecutor to have access to this data prior to while they're investigating a crime?
As the data comes in, give law enforcement access to the CMS systems, protect privacy, but give us access to the billing pattern so we can catch the fraudsters in the act.
Would you need to go to a judge to get access, or you just want to be able to have access to it?
Correct, yes.
So you could call up the Health and Human Service and say, we have this particular case, this particular modeling, we want you to give us access so we can look at the data.
Not call up HHS, but actually put our investigators, we have a facility in South Florida. We'd like a computer terminal there where we can go and see billings for X drugs spiked by 300% in the past month for these 5 providers. Well, maybe that's a reason we should investigate those 5 providers.
Well, the gentleman you
Sure, glad to hear.
Is that a legal barrier that you couldn't get the data, or is that an agency policy that prevented you from getting it?
In all candor, I am uncertain whether it is legal or bureaucratic. I just know it's a barrier.
It would really, as I said to the previous panel, I think that's some data that would be really helpful in these investigations. So if you can try to figure that out and supplement your answer, then we can know what we need to do to help expedite that. Thank you, Mr.
Thank you. Let me conclude by, good. We got another member came back, gentleman from Texas. Mr. Burgess is recognized.
Thank you, Mr. Chairman. Actually, I've been watching off the floor. I have a couple of constituents that are here. They're both serving their country, so I'm making some time for them while this hearing is going on. Let me just ask a question, Ms. Rosenbaum. Well, actually, I want to ask it of Mr. Smith, but Ms. Rosenbaum made an observation that we should empower more investigation of fraudulent insurance behavior. But Mr. Smith, some of your testimony to me indicated that you didn't feel that it was necessarily the same focus. Would you care to expound upon that?
I think what I said came at maybe a slightly different angle. I said one of my recommendations was that the Medicare and Medicaid programs continue to move away from a fee-for-service based system and more toward other payment systems such as managed care, and also to operate the programs more like a private insurer would. I guess it might be interesting historically to hear what percentage private insurers have suffered in fraud and abuse, but that goes to their bottom line. It doesn't go to taxpayer dollars. What the Medicare and Medicaid programs need to do is focus on protecting taxpayer dollars. And if you engage an outside managed care company and you pay them risk-adjusted rates, they have the financial incentive to stop the provider fraud and abuse. If they don't, it goes to their bottom line. It doesn't hurt taxpayer dollars any further.
Yeah, and that's interesting that you say that. When was this? June of 2009. You may be familiar with an article published in the New Yorker by Atul Gawande. And it was important to me because he was talking about Texas And I should point out that Texas today is 175 years old. It was 175 years ago this morning that Texas declared its independence and became an independent country. But that's another story. Part of Dr. Gawande's investigation in South Texas led to him, I don't know that he came right out and said it, but he certainly implied that overutilization and overbilling of Medicare was rampant within the medical community in McAllen. So it bothered me. I know a lot of doctors, or I know some of the doctors who work there. We've worked together on border issues. So I took a trip down to McAllen to see for myself on the ground what, if I could, what was going on. And just the point you make, Mr. Smith, was you don't see the headlines in the paper that Aetna Life and Casualty has been defrauded of 15 wheelchairs. It just doesn't happen. It's always Medicare, Medicaid, S-chip. It's always the public side. Now, Ms. Rosenbaum has some issues with the private insurers, and I get that, but here we're talking about the actual delivery of care inappropriately. It never seems to happen on the private sector, or if it does, perhaps they just don't talk about it the same way we do on the public side. But is that your observation as well?
It's certainly been a prevalent problem in both programs. There was a report recently that in 2009, the Medicare program paid for over 420 million claims for mental health in Florida alone, which was 4 times higher than the amount paid in Texas and 635 times higher than the amount paid in Michigan. And to paraphrase Carl Hyacin, who's a funny novelist out of Florida, he said, no matter what you think of Floridians, there's no way that we are 4 times crazier than Texans. Respectfully, Congressman. So.
Well, exception taken. Yeah, I was going to suggest perhaps they need to move to Texas, and that would solve our problem. Well, it's just, it raises an important issue. What is happening on the private side that prevents the same problems that are happening on the public side? Now, we talked a little bit about the payment error rate, and Ms. Rosenbaum, some of that is truly just a coding error. Someone makes a mistake when someone comes in and they write the code down, and that goes into the payment error rate, correct?
Absolutely.
But that error rate of 9.4% or whatever was quoted to us, that's not predominantly made up of honest mistakes made in tallying up the office visit. Is that correct?
I'm not sure I understand the question.
Well,
of the total amount.
Yeah, how much is just going to be simple coding errors
I couldn't begin to answer the question.
It wouldn't involve these 2 guys that were on the panel earlier with their handcuffs and nightsticks. It wouldn't be involved, right? The amount of the error rate that is just attributable to simple coding errors is likely pretty small out of that 9.4%.
I truly don't know. I've only seen the numbers aggregated.
Well, let's even say this. Let's say it is that high for just simple coding errors. Doesn't that tell us something about how we should be approaching this problem? That, if nothing else, perhaps some education of doctors and nurses and clinics about how to code properly would be part of what should be happening at the level of CMS?
Yes, I think anything and everything that can be done to clarify how to bill, how to file appropriate claims.
Now, I don't have any data on it, but I would suspect that number is very low because, as you recall, in the late 90s, there were all of these compliance audits. And I know, because I was in practice at the time, and they were very, very severe. And, yes, you could be put in jail. So I'm just telling you, I think that number of actual coding errors in that 9.4% is, in fact, very small. Because most physicians and nurse practitioners do not want to undergo that type of scrutiny because we all had to go through those compliance audits. We all had to put forward what we were doing in our offices to prevent that from happening. Mr. Chairman, I see I've gone over my time. Thank you for the indulgence.
All right. I thank the gentleman. By unanimous consent, we'd like to put the document binder into the record. And I'll conclude by saying the purpose of the oversight investigation is to ferret out details. You've done an excellent job, this second panel here. We are going to recommend to the Health Subcommittee on Energy and Commerce a lot of the recommendations that have come out of this hearing, and that's the purpose. And hopefully we'll have a hearing and follow up with legislation. I know the Democrats think a lot of these suggestions you've made are part of Obamacare, but I'm not sure they all are. And obviously changing the Social Security number so a person can have a Medicare ID number that you seem to all agree upon is something that I think we should look at quickly. So with that, the
Mr. Chairman, just a point of personal privilege.
Sure.
Could I recognize two of my constituents who
Sure,
are in the
go
back
ahead.
of the room?
Yeah.
Captain Dombravo and Captain Dombravo were visiting me today during the hearing, and I want to thank them for their service to the country. If I can further relate, my relationship with Captain Dombravo goes back some time without violating HIPAA. I delivered him 27 years ago.
Okay.
So thank you both for being here with us today.
Thank you for being here. And with that, the subcommittee is adjourned.